So this bag is going to be given through the central vein, that is known as total parenteral nutrition. So please don't forget, total parenteral nutrition is giving of this bag is known as total parenteral nutrition. So please don't forget, very good comment, that's for fatty liver. Yes, I told it is for a fatty liver. So this is a central vein. You can see the picture showing you a central vein inserted in the subclavian place, subclavian location. We have put a central vein. This, after inserting this subclavian vein or IJV, you should take an X-ray. Can you see this X-ray? This question can come as an image-based question for you. So as per image-based question shown here, what is shown in this image? I can see a catheter kept in the superior vena cava. That is a central vein catheter which is in position. First important thing I should look in this is I should see the central vein catheter should be in the superior vena cava number 1. It should be there in the superior vena cava number 1. Number 2, there should be no pneumothorax. For these two reasons, I will take an X-ray. That X-ray will show there is no pneumothorax, and that will show you that central vein catheter tip is present in the SVC. And in this patient, what is the complication seen? In the image you are seeing here, there is one complication seen. That is why this picture is shown. There is a redness, pain, erythema, tenderness at the point of central vein catheter, and patient is complaining of fever. All these are clinical questions. A patient with a central vein catheter is complaining of fever, tenderness. What you should think of? I should think of catheter related sepsis. So the catheter can cause infection because of mishandling by the staff nurse or by the oxygens there. They may contaminate the catheter and it can cause some infection. Now the question is, this central vein catheter getting infected, how to confirm? How will you confirm it is a catheter related sepsis? Please remember how to confirm catheter related sepsis. Simple method, I will take peripheral blood. I will take a peripheral blood for culture sensitivity, and also I will take a central blood through the central vein catheter. I will aspirate. So central vein blood will be sent for culture sensitivity. If both are same organism, it is confirmed catheter related sepsis. If both are same organism, it is catheter related sepsis. I should remove the catheter and I put a new catheter on the opposite side. So please remember, if it is catheter related sepsis, the catheter should be removed and put a new catheter on the opposite side. So this is a high yield MCQ. I am taking all the questions which I am taking today are clinical based questions only. I am not taking any theory questions. So please understand the clinical based questions. So clinical situation is on the right side. I am writing the answer on the left side of the board. Okay, this is the first important chapter, parenteral nutrition. So the second important chapter which is to be known as shock. I am going to discuss entire surgery in 2 hours. So please be active and don't try to write notes and all, not needed. Just listen to the class. And this video will be available. I will share this PDF also with you in the Telegram group. You can use it. So monitoring of shock, the best clinical parameter, 1000 times asked MCQ, you should never miss this MCQ. Best clinical parameter is urine output. So the question is best clinical parameter. Central vein pressure is the best parameter for what? It is the best parameter in a shock to give fluids and drugs. Fluid and drugs. I want to calculate the dosage. For that, this is the best. Central vein pressure is the best for calculating fluids and drugs. Serum lactate. It's a new lab value. If it is more than 5 millimoles per liter, you have done a poor resuscitation. Your resuscitation is not good. If it is less than 12 millimoles per liter, you have done a good resuscitation in a shock patient. So the best lab value to know the shock is serum lactate. So please remember the 3 questions. Best lab value to monitor the shock is serum lactate. Best clinical parameter is urine output. Best parameter to give fluids and drugs for a shock patient is CVP. And there is one more question which usually students gets confused. Best parameter for adequacy of resuscitation. That is also urine output. Best parameter for adequacy of resuscitation. Adequacy of resuscitation is also urine output. So that is most important MCQ for organ perfusion. You have done a good adequate resuscitation. Everything is by means of this urine output. Okay. So please don't forget anything about Foley's catheter. So Foley's catheter is a high yield clinical based question. Definitely you will get MCQ from this. Please don't forget this. 3 important color codes I want you to remember at this point of time, especially with the 10 days exam. You should remember the 3 color codes. Number 1 green, number 2 red and orange. So please note what are these. Green code, what does it stand for? Orange code, what does it stand for? And red is for what size? So these 3 size I want you to remember for your exams. So green is 14 French. The size of the catheter is 14 French catheter, and green is used for girls. Remember G for G, girls. Orange is most commonly used. 16 French catheter is most commonly used catheter. Most of you when you go to the hospital you will see only a orange catheter, that is 16 French. Red is a big size catheter, 18 French. It is used after TURP, transurethral resection of prostate, for irrigation purpose. Since it is used for irrigation purpose, you can see 3 lumens. You can see 3. 1, 2, 3. 3 lumens are there for irrigation purpose. Otherwise, we will have only 2 lumen. One is for inflating this balloon. One is to inflate the balloon. So, how will you inflate this balloon? The balloon is inflated with the help of distilled water only. Very good. Most of you are answering very well. So, any doubts you can post. I will be stopping for your doubts at in between the gaps. So this is a distilled water which is used to inflate the balloon. The balloon will be inflated with the distilled water only. Don't use anything else. Especially normal saline is contraindicated, because if you use normal saline, that will crystallize and obstruct the balloon. And if you want to remove the Foley's catheter, you will not be able to deflate. Therefore, distilled water is only used. Don't use normal saline for inflating the balloon. Okay, please don't forget, normal saline is not used. And there is a recent NEET PG question. A patient had a Foley's catheter and the catheter is retained. You are unable to remove it. How will you remove the catheter now? Retained Foley's. You are unable to deflate. I am unable to deflate. It is retained. What will I do now? What will I do? It is unable to deflate. So distilled water can be from 10 to 15 ml can be inflated. It will be distilled water, 10 to 15 ml will be inflated. Unable to deflate. The correct answer for this from exam point of view, under ultrasound guidance, I will puncture the balloon. Please remember, I will puncture balloon under ultrasound guidance is the correct answer for this question. So you should not overinflate it. Overinflation is wrong. Trying to cut the tube is also wrong. The correct answer is ultrasound guided puncture of the balloon. That is the correct answer for this question. And there are many colors. For FMG exam, they will ask only these 3 colors: green, orange, red. If at all you can remember extra one thing, black is for pediatric. Black child, remember black child 8 French. Okay, so these are the most important thing. These are the 2 types of Foley's catheter we have. This is a typical latex rubber made catheter. Latex rubber made. What is the second one? Can you tell me what is the second catheter? The second catheter is silicone catheter. Silicone catheter is used for patients who need to be having the catheter for long period. We can use the catheter for 3 months. Whereas the latex rubber catheter will be used only for 15 days to 1 month only maximum. Otherwise, we have to change the catheter very frequently. But 3 months it can be used for silicone catheter. So for people who are having long-term catheter, they will be using silicone catheters. And the problem with the latex rubber is it can cause latex allergy can happen. Allergy is seen with latex rubber catheters. So these are the most important points from Foley's catheter. And this is a regularly asked NEET PG question, classification of hemorrhagic shock. I hope you will be knowing there are 4 classes of hemorrhagic shock. 1, 2, 3, 4. There are 4 classes of hemorrhagic shock. 1, 2, 3, 4. Class 1 shock is a shock where there is 0 to 15% of your blood is lost. Up to 750 ml blood is lost is class 1. 2 is 15 to 30% of your blood is lost. 750 to 1500 ml. This question is a repeat question for a national board exam. So please don't forget, 30 to 40% is 1500 to 2000 ml blood is lost. So more than 40% blood is lost. It is more than 2 liters blood is lost. These are the 4 classes of hemorrhagic shock, and in which of this shock the pulse rate start increasing. So class 1, no symptom at all seen, no sign seen. It is a compensated shock. Up to 750 ml blood if you lose, nothing will happen to you. You will be sitting normal. That is similar to blood donation. If you donate blood, you donate 450 ml blood, nothing will happen to you. You can just like that walk out. Whereas class 2 shock, you will have increasing pulse rate. Please remember, the pulse rate increases in class 2. Blood pressure, systolic blood pressure starts falling from class 3. Please remember these two MCQ points at this point of time. Systolic blood pressure will start decreasing only from class 3 shock. Pulse rate will start increasing only from class 2 shock. Okay, so please don't forget this point, very important for your exams. Okay, resuscitation of hemorrhagic shock. This is a high yield MCQ for AIMS exam and expected in FMG exams also. What is the color of Venflan we use? Color of cannula we use. So I hope you should not forget the colors of various cannulas. The color of cannula we use is 16 gauge cannula is used, green color. It should be used, 2 cannulas should be used for resuscitating a hemorrhagic shock patients. Both sides you should put 2 cannulas, 16 gauge green cannula is used. So this is the commonly used cannula or the advised cannula as per ATLS guideline. Advanced Trauma Life Support guideline is this. But if I want to give more fluid, what is best? If I want to give more fluids, I can use also the following cannulas. 16 gauge gray can be used. This question has come many times. So, sorry, I have mentioned wrongly here. It is 18 gauge green. It is not 16. 18 gauge is green. This is 18 gauge green. 2 cannulas should be used in trauma. Gray is having high amount of fluid. 14 has more amount of fluid. More or highest fluid can be infused. Highest fluid can be infused with orange, gray, green. I want you to remember these 3. These 3 are important for exams from this cannulas. It is usually common for students as well as even for the faculties. We get confused with the cannula size and the French size. So French and gauge are different. So here, as the gauge becomes smaller and smaller, can you see it is a reverse value. It's a reverse value. Gauge is a reverse value. As gauge comes down, 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 the diameter of the cannula increases. Diameter increases as number decreases. Very important thing. So see, 18 gauge is green, 16 gauge is gray, 14 gauge is orange. So which is biggest among this? Means 14 gauge is the biggest. As house surgeon, most of you would have used the 2 cannulas commonly, that is green cannula will be available in the adult ward, and pediatric ward they will be using 22 gauge blue, and newborn ward they will be using 24 gauge. So newborn wards they will be using this yellow cannula, pediatric ward they will be using this blue cannula 22 gauge, and adults in our general ward we commonly use this green cannula only in practice. So adult ward we use this green and pink. These are the 2 colors we use in adult wards. So please don't forget the color of cannula, Foley's, etc. These are very, very important for your exams. So which one has the highest fluid? Highest amount of fluid can be transfused with which of the cannula? Means answer is orange cannula. If orange is not there in the choice, go for gray cannula. This question is a repeat question in NEET PG exam. Okay. So most of the time they will not give orange 14. They will be giving 16 gray. Go with that if it is present. So then coming to the blood packets. These are the blood packets I am going to tell you now. So is essential points I want you to know from the blood is, this is a whole blood. Whole blood is 450 ml. 450 ml is whole blood, which is containing a preservative solution SAG-M, saline adenine glucose mannitol. This is the latest solution we are using. Nobody uses the old solution. CPD, citrate phosphate dextrose, is not used now. Citrate phosphate dextrose not used now. We are using saline adenine glucose mannitol only. So saline adenine glucose mannitol only is used nowadays. So please remember, this can store the blood for 45 days. The blood can be stored for whole blood. What you are taking from the patients, from the donors, can be stored in the fridge at a 2 to 6 degrees centigrade. For 4 to 5 days you can store the blood. Very important MCQ. How long can you store the blood? It is for 45 days. At what temperature you store the blood? 2 to 6 degrees centigrade. And from this whole blood only I will prepare multiple components. You know, I will be preparing multiple components like fresh frozen plasma, as shown in this image. This is fresh frozen plasma. The second one is cryoprecipitate. and packed cells, packed RBC, which is used in gynecology ward, obstetric people, they use packed red blood cell for pregnancy. So this is packed red blood cell, which is 330 ml. The capacity is 330 ml. FFP capacity is around 250 ml. Cryoprecipitate is 15 ml. So now the question for your exam, typical FMG question is, at what temperature will you store FFP and cryoprecipitate for how long? They are stored at minus 40 degrees centigrade. Minus 40 degrees centigrade for 2 years. They can be stored for 2 years. Please remember, very important point from your exams. So this FFP and cryoprecipitate can be stored at 40 degrees centigrade for 2 years. That's an essential point you should not forget. Okay. So this question is, FFP shelf life is 2 years at minus 40 degrees. Cryoprecipitate shelf life is 2 years at minus 30 to minus 40 degrees centigrade. And high yield MCQ for FMG exams is platelets. Platelets. This is actually a pathology topic, but it is given there in Bailey, so I am taking from Bailey and Lau. Platelets will be stored at room temperature. That is 20 to 24 degrees centigrade. So at 20 to 24 degrees centigrade room temperature, they are stored on an agitator. It cannot be just like that kept in the fridge. It should be kept on an agitator which will always continuously shaking, and it can used only for half-life is how long? Definite MCQ for FMG exam. This is a definite question. Half-life is only for 5 days. You can use it only for 5 days, not more than that. So there is one problem with the OBS software using this type of classes is, when I ask the question, that question will reach you after 2 minutes. Anything you type also will reach me after 2 minutes. So that is the problem. We cannot have an active interaction like in Zoom. In Zoom, we can have an active interaction. The moment I ask a question, you will immediately post the answer. But this is a huge delay will be there. See, now only I am getting a question answer of 5 days from Amrita and Avilo. But I asked this, I completed this 2-3 minutes before. That is a problem. But any doubts, you can always type on that. I will answer that. So very good. All of you are correct. It is off days for platelets. It's off days for half-life is 5 days. Okay. So now coming on to the most important topic, that is on suture materials. Suture materials is a high yield topic, clinical based topic for FMG exams. This is a catgut. I am going to tell 5 properties for each suture material. Remember these 5 properties for last minute exam. Catgut is an absorbable suture material. Absorbable suture material, number 1. Number 2, it is stored in. No other suture material needs this solution. It needs a solution. What is it? Yes, Aruna, I am Tamil only. Why suddenly you are having doubt? So stored in what solution? So plain catgut is stored in isopropyl alcohol. So isopropyl alcohol, it is stored. Third question. It is the solution it is a suture which is having highest enzymatic reaction. Highest enzymatic reaction. I will definitely finish today itself, Rishabh, if there is no disturbance in between by many doubts. If there is no doubts, I will finish entire surgery in 2 hours. So highest enzymatic reaction is seen with this catgut suture material. Please don't forget this. It is degraded by enzymatic degradation. Enzymatic degradation. Since it is having highest enzymatic reaction, it will cause wound reaction will be more. So because of this problem, it is banned in UK. It is not used in UK. It is still used in India. It is banned in UK. And even vegetarian people, they will be telling not to use this because it is derived from sheep's submucosa. So vegetarian people, they don't like using the suture. They will tell him usually before itself that they can have allergic reaction. So sheep's submucosa, it should not be used. Okay, it should not be used in vegetarian people. We avoid it. So coming to Vicryl. Vicryl is an absorbable suture material. It's an absorbable suture material. It is multifilament material. What is actually Vicryl? Vicryl is nothing but polygalactic acid. Polygalactic acid is known as Vicryl. It is multifilament material. First point, absorbable. Second point, multifilament. It is absorbable in 60 to 90 days. Catgut is absorbed in 10 days. Plain catgut is absorbed in 10 days. 60 days for chromic catgut. So all these are high yield MCQ points. 60 days for chromic catgut, 10 days for plain catgut. Okay, so absorbable suture materials are seen for 60 to 90 days. Multifilament material is used for Vicryl. So the third point, it is polylactic acid. It is absorbed by hydrolysis. It is absorbed by hydrolysis phenomenon. The fourth point is most important. This is the suture material used for which anastomosis? Suture material used for bowel anastomosis and bile duct anastomosis. We use Vicryl. So for bowel and bile duct anastomosis, we use Vicryl suture material, and Vicryl is a company name. The original name is polylactic acid. So the most important suture material for FMG exam is this Prolene, which is nothing but polypropylene. So you can see from seeing the material itself, I am telling you this is Prolene because there is an interesting property seen. What is that property? The property shown here is memory. When I stretch other suture materials, they will get stretched, but this Prolene will not get stretched. It will coil back. It is a good property or a bad property? Means it is a bad property. Please remember, having memory is a bad property of Prolene, and it is a monofilament material. It is non-absorbable material. It is non-absorbable material. It will remain in your body for lifetime. It will be remaining in your body for lifetime. Okay, so it is memory, monofilament, non-absorbable material, and most interesting and important thing is it is used for hernia repair. Hernia repair, abdominal wall closure, etc., etc. It is used in multiple places like this. So most important thing is hernia repair and abdominal wall after laparotomy, used for abdominal laparotomy closure. Okay, so please don't forget this Prolene suture material. So now I am showing you some image based questions directly based on the sutures. This is a simple suture showing you the knots are simple knots. So this is what? This is simple suture. What is this suture? What is this suture? These are all direct image based questions, self-explanatory. This is horizontal mattress. It is an horizontal mattress suture. It is a vertical mattress suture. So vertical mattress, horizontal mattress, simple. All these are skin sutures shown here. All the skin sutures are having a specific time to remove. The scalp suture removal, when it is done, is a repeat MCQ for your exam. Scalp suture is removed on 6th to 8th post-op day. So please don't forget, when you have a scalp suture, it should be removed on 6th to 8th post-op day. So there are two types of mattress. Please observe, it is horizontal like this, it is vertical like this, vertical mattress. Okay. So this is a continuous suture which we are not commonly using in practice. This is a purse string suture. If there is a hole like this, I can close it by a purse string. Like a purse string like this, if I pull, the suture will get closed. This is a purse string suture. So all these are last minute images to be remembered for your exams. And coming to the most important thing, that is needles. This is a commonly used needle, nothing but half circle needle. So usually the exam, for FMG exams, they will ask you the common materials only. They don't ask you the rare questions and all. But half circle needle is the one which is used for bowel and bile duct. So bowel and bile duct, we use this half circle needle. Can you see there is a quarter circle needle? This quarter circle needle is used for ophthalmic surgeries. Ophthalmic surgeries. So one more question you can get in exam is this J-shaped needle. Can you tell me where is this J-shaped needle used? Quarter circle needle for half circle, quarter circle needle for ophthalmic, and this J-shaped needle is used for episiotomy closures or for vagina operations. They use this J-shaped sutures. So the sutures, the needles are having the following shape. This is round body needle. This is cutting needle. When you cut and see the central place, it is cutting needle. So this is cutting, and I am going to show you now the reverse cutting needle. So this is the reverse cutting needle. See, round body needle, cutting needle, reverse cutting needle are the three shapes of needle. Round, cutting, reverse cutting needle. Okay, so these are the three needles. You want to zoom this. So J needle, semicircle, this is a quarter circle, this is semicircle. These are the three needles I want you to remember. Other things don't worry. Other things they may not ask you. They will ask you only these three needles. J needle for episiotomy, ophthalmic surgeries, they use quarter circle. Okay, so now I am going to show you fast the instruments alone. So definitely you will be asked questions from instruments. Be fast on the instruments. This is a 11 size blade. Can somebody tell me what is the use of 11 size blade? So 11 size blade is used for stab incisions, for incision and drainage, for arteriotomy, for opening the artery, arteriotomy. So stab incision, incision drainage and arteriotomy. So these are the things we use. So there are 3 needles, round body, cutting, reverse cutting. So please don't forget, the best is reverse cutting needle, which is less traumatic to the tissue and easily it can penetrate. Easily penetrates and less traumatic is best is reverse cutting needle. Reverse cutting is less traumatic and easily penetratable. And 11 size blade, please don't forget, it is used for stab incision, incision drainage and arteriotomy. So this is a 22 size blade used for long incisions. This is 15 size blade used for small incisions. Okay, small incisions, we use this 15 size blade. So please don't forget this blade's shape and all. So I hope you will be remembering this. This is a bipolar probe used for surgeries. There is no need of earth plate in this case. No need of earth plate for this bipolar probes. No need of earth plate for these cases. This is a monopolar plate. Monopolar probe. We need an earth plate. Earth plate should be kept. There are 2 buttons. Yellow button is for cutting the tissue. Blue button is for coagulation of the tissue. This is a commonly used probe in practice known as monopolar probe or a monopolar diathermy. Earth plate is must. This probe is the most common cause of electrical burns in the operative patient. In electrical burns in operative patient is usually due to this monopolar probe. And you can get this question also. This is an excellent question. Harmonic scalpel, it works on the principle of ultrasonic waves. It works on the principle of ultrasonic waves. It has a precise cut. Please remember, it is having a precise cutting is present with the help of harmonic scalpel. Okay. So what is the name of this catheter? These are all directly one-liners. You should not make mistake in this type of instruments. And this is a Mallicot's catheter. You can see the tip is having like a flower. When you stretch, it becomes straight. So it is Mallicot's catheter. So this is a retractor shown here is used to retract the liver. So this is a liver retractor known as a Devers. This is a Devers liver retractor. So this is a Morris retractor used on the ribs to retract the ribs. So this is a Morris retractor used for retracting the ribs. Don't get confused between this and Langenbach. So Langenbach will have a small blade. It will not be this much big. I'll show you. This is Langenbach. Both look like same. Morris will have a wide blade. Langenbach will have a narrow blade. This is Langenbach retractor. This is Langenbach's retractor. Okay. So please remember, this is Langenbach's retractor. So this question can come for your exam. This is highly expected MCQ for your exams. It is having 2 ends. One side we have a splitted retractor and another side we look like a Langenbach. This is looking like an Z. So remember, Z for Zerny. Z for Zerny. Okay. So this is Alice tissue forceps. Alice tissue forceps, which is having multiple tooth to hold. Alice tissue forceps. So identify this forceps. This is a Babcock's forceps used to hold the bowel. So bowel holding Babcock's forceps is shown here. So this question has come in NEET PG exam. I want you to remember, this is a Veris needle. Okay, this is a Veris needle shown here. So Veris needle is a needle used for laparoscopic gas insufflation, for a closed technique of CO2 gas insufflation. So this question can come for your exam. This is Veris needle, CO2 gas insufflator needle. So this is a typical robot which is available now in the market. It is Da Vinci robot. Okay, Da Vinci robot is a robot available in the market which is directly taken image from Bailey and Lau. Please don't forget Da Vinci robot for your exam. It has 7 degrees of movement. 7 degrees of freedom is available for this robot. It can move in 7 directions. Okay. So coming now to the next chapter, that is on trauma. The high yield points from trauma I am going to tell you now. So I hope you are following the classes. So don't worry, I will share this PDF. This is what I am writing. This will be shared with you. You can read for your exams. This is triage. Triage means sort out in a mass casualty. Sort out in mass casualty. When there are many accident cases coming to you, you have to triage the patient. The patient which needs a treatment within half an hour is given a red badge. The patient who needs a treatment in 1 to 2 hours is given a yellow badge. Green is given for patients who can be treated casually. Casual treatment can be done. Nothing to worry. They won't die. So the second important is yellow. The third important is green. So the green people are called as walking wounded. Green color badge is given for people who can directly come to hospital by themselves. No need to even transport by ambulance. They are walking wounded people. So example of walking wounded are they have a ulnar fracture, radius fracture, small injuries. So this and all are the various things which are presenting to the hospital. So green is walking wounded patients. Okay, walking wounded patients are green. I want you guys, please don't go to exam without knowing GCS. Glasgow Coma Scale will definitely give you 1 mark in your exam. Every exam will get questions from Glasgow Coma Scale. So please remember a simple method I will tell you. Eye opening is one thing, verbal is second, motor is 3. You will be asked to calculate the GCS in any patient. Eye opening, if a patient spontaneously opens, it is 4 points. You call him, you are calling Ramu, Mr. Ramu, Mr. Somu is opening. On call he is opening, or calling you are opening 3 points. On painful stimulus only is opening 2 points. Not opens is 1 point. So please remember, spontaneously opening 4 points, on calling he opens is 3 points, on painful stimulus 2 points, not at all opens is 1 point. Verbal response, I'll tell you, you have to remember one confused word sounds nowhere. This is a mnemonic for this. It's a simple mnemonic. One confused word when you use it sounds nowhere. This is a simple mnemonic. So yellow is also a fracture. Yellow is a major fracture, not a minor fracture. Yellow will be a fracture of femur. Like that, major bone fracture will come under yellow. So I am telling you, a patient who can walk and come to hospital is green. Black is moribund and dead and about to die. We cannot save them even if you ship them to hospital. So black is moribund and about to die. So verbal response, please remember, one confused word sounds nowhere. So 5, patient is oriented. Confused 4, inappropriate words 3, inappropriate sounds 2, no sound at all is 1. That is simple. You remember the mnemonic, you can answer the question. One confused word sounds nowhere is a mnemonic for verbal. The last mnemonic is obey localites, local people with flexion and extension now. Obey local people with flexion, extension now. That's a mnemonic for last one. 6 points are there for motor. Obeys, you see, obeys commands is 6 point. Obeys command is 6 point. Localizes pain is 5 point. When you touch him, he is withdrawing. Withdrawal is 4 point. Flexion deformity is seen. That is, what is that? Flexion deformity means it is deep corticate rigidity. That is 3 points. Decerebrate rigidity is 2 points. Okay, decerebrate rigidity is 2 points. And no response is 1 point. So simple mnemonic. So you will definitely get a clinical question from GCS. Remember the mnemonic. One confused word sounds nowhere for verbal. Obey localites with flexion extension now for motor. Simply you can answer any question. With this mnemonic you can definitely get one question and you can answer the one question. Okay, please don't forget GCS for your exam. Okay, very good. So now I am showing you some images of trauma patients. You have to find out what is the finding. So can you find out what is this patient? This patient is having a head injury. He is having a fixed dilated pupil on the right side. Can you see? This is known as Hutchinson's pupil. Hutchinson's pupil is a finding of head injury. Fixed dilated pupil. That is known as Hutchinson pupil. It is usually seen on ipsilateral side. The side of head injury, that side pupil will get fixed and dilated. That is Hutchinson pupil. Can you see that pupil is dilated here? So that pupil is showing you fixed dilated pupil is known as Hutchinson pupil. So what is this picture showing you? This patient is having a base of skull fracture. It is a base of skull fracture. Patient having an eyes known as raccoon eyes. It is a raccoon eyes due to anterior cranial fossa fracture. Okay. So anterior cranial fossa fracture, it is raccoon eyes. So please remember guys, for a patient who is intubated, there is a question, very nice question from Shelki Deepak. For a patient who is intubated, the score is given as VNT. That is verbal not testable. Verbal not testable, and you don't give points. No point for that. No point for that. Verbal not testable, no points for that point. So don't add that point. If a patient is intubated, you add eye opening and motor alone. So verbal will have no point. No, don't give 1 point or anything. So okay. So this is raccoon eyes for base of skull fracture? And this is 100 times, no, 1000 times asked FMG question. A patient having a middle cranial fossa fracture. So middle cranial fossa fracture will have this battle sign. This is known as battle sign. Very good. So battle sign. So this is battle sign. Okay. So this question is a very commonly asked question. This is a biconvex hematoma in a trauma patient. This is extradural hemorrhage, and these guys will have lucid interval. A period of consciousness before they go unconscious is EDH. Having a biconvex hemorrhage, it is due to injury of middle meningeal artery injury. The reason for this EDH is middle meningeal artery injury causes this EDH. This is a concavo-convex hematoma. Concavo-convex hemorrhage. This is subdural hemorrhage. The patient will be having history of loss of consciousness from time of injury. From the time of injury, they will have loss of consciousness. So these guys will need a decompressive craniectomy. They will need a decompressive craniectomy is needed for these guys. The previous fellow will just need a burroll. Burroll evacuation will be needed for this guy. So burroll evacuation is needed for EDH, and SDH will need a decompressive craniectomy for the patients. So now there is a question which is changed in ATLS manual. This is a tension pneumothorax patient. We are putting a needle in the second intercostal space at mid-clavicular line, old concept. Where will you put a needle in a tension pneumothorax? Old concept is second intercostal space, mid-clavicular line. The recently changed ATLS manual latest edition. ATLS manual latest edition says you should put it in the mid-axillary line at fifth intercostal space. This is the latest concept. Okay. The latest answer for this question is, where will you put a needle in a tension pneumothorax? In the fifth intercostal space in mid-axillary line for adults. But for children, where will you put the needle? Children, it is the same mid-clavicular line, second intercostal space is same for children. Children, they have not changed. They have changed it only for adults. They have changed it only for adults. Okay, please don't get confused in this. This is a very basic FMG question. You will definitely get in exam. So if I am going to put an ICD, I will put it mostly intercostal drainage tube is usually put in the fifth intercostal space, mid-axillary line. This is the place we put ICD in practice. So this is ICD related question. You can see here. There is an intercostal drainage tube being put. The safety triangle of intercostal drainage tube. I am going to draw the safety triangle. See the safety triangle I have drawn now. This is a safety triangle. The boundaries are pectoralis major muscle is one boundary anteriorly. This is latissimus dorsi muscle posteriorly. And this is a line at fifth intercostal space, otherwise line at nipple. At the level of nipple, I am drawing a line. Okay, actually, I should draw a line at the level of nipple. So please understand the image. So this is a latissimus dorsi muscle. This is pectoralis major muscle, and at the level of nipple, I should draw a line horizontally. So this is a triangle known as safety triangle of ICD. Safety triangle for intercostal drainage tube is bounded by pectoralis major, latissimus dorsi, and line at fifth intercostal space. Please don't forget this thing. Okay, this is very important for your exams. So what is your diagnosis seeing this picture? So this is a picture showing you multiple ribs are fractured. More than or equal to 3 ribs fractured in more than or equal to 2 places. What is it known as? From Bailey and Lau. This is known as flail chest. Please don't forget. More than or equal to 3 ribs fractured at 2 or more places. So guys, I don't know Hindi. Some of you are typing in Hindi. I could not understand it. So if you have a doubt, please type it in English. Okay. So 3 ribs at 2 places. This is flail chest. Okay, this is a flail chest. These patients will have hypoxia because of pain. Because of hypoxia, they will have pain. So what I should do? So investigation of choice for this now is CT chest. 3-dimensional CT chest is the investigation of choice. The important prognosis of this patient is based on underlying lung injury. Sometimes what happens? Underlying lung injury will be there. That is a major issue with these patients. So the first line treatment of these patients is heavy analgesics. We should give them heavy analgesics, and if saturation falls less than 60%, I should intubate the patient and give IPPV. So if the saturation falls less than 60%, I will put a intermittent positive pressure ventilation. I should put a intermittent positive pressure ventilation if it is falling less than 60%. So around 1000 students are attending the class. It's highest number of people attending the class in an online session. This is the first time I am seeing in YouTube. So please don't forget, this is a flail chest. Never forget this for your exam. So this is a question. This is a very important question. What is going on here is, I have put a patient of abdominal injury. I have cannulated the umbilicus with the catheter, and I am going to infuse 1 liter of ringer lactate. I am going to infuse inside. I am going to infuse 1 liter of ringer lactate, and I am going to examine the fluid. So this test is known as diagnostic peritoneal lavage. This is diagnostic peritoneal lavage, where more than 1 lakh RBC per ml or more than 500 WBC per ml or more than 10 ml frank blood coming as shown in this image, it is said to be positive. So diagnostic peritoneal lavage is an old investigation of our days. So when we are doing MS surgery, at that time we will be using this DPL to diagnose the abdominal injury. More than 1 lakh RBC, more than 500 WBC per ml or more than 10 ml frank blood is coming, it is said to be positive. The major drawback of this investigation is, it cannot detect what? It cannot detect retroperitoneal injuries. Please don't forget this one-liner MCQ. Last year asked in AIMS. So diagnostic peritoneal lavage can diagnose everything except retroperitoneal injuries. It cannot diagnose retroperitoneal injuries, and this investigation is totally replaced now by E-FAST. I think you would have discussed this E-FAST yesterday with Dr. Khalil sir in class. This is E-FAST. In E-FAST, how many regions are focused? Can you tell me? In E-FAST, how many regions are focused? Old FAST was only 4 regions. Now we focus at 6 regions. Right side liver, left side spleen, pelvis, epigastric region, and right side chest, left side chest. So 6 regions: liver, spleen, epigastric region for heart, and 4 is pelvis, 5 is right side chest, 6 is left side chest. So E-FAST is used for 6 regions. It is a non-invasive test. The major drawback of E-FAST is, it cannot detect bowel injury. Not detect bowel injury. It cannot detect bowel injury. Please remember, this is the last year MCQ. It will not detect retroperitoneal injuries also. Not detect retroperitoneal injuries also. But please remember, this is the first done investigation in abdominal injuries. First done investigation for a patient coming to hospital with an abdominal injury. The first done investigation is E-FAST. E-FAST is the first done investigation for abdominal injuries. And in E-FAST, this question is a highly expected MCQ. If you get a stratosphere sign, it looks like a seashore sign. This is barcode sign or stratosphere sign. So this stratosphere sign in the lung or barcode sign in the lung is seen in pneumothorax. Please remember, it is a finding of pneumothorax. So actually surgery books have mentioned wrongly, seashore sign is a normal finding. Okay, it's a normal finding. But some books have also mentioned seashore sign is also seen in chest trauma in pneumothorax. So pneumothorax can also be diagnosed by E-FAST. Very interesting point is, E-FAST can also diagnose pneumothorax. So for FMG exam, I want you to remember what is the most common organ injured in abdomen in each injury. In a blunt injury abdomen, the most common is spleen followed by liver. Only remember one organ. The first organ don't forget. So most common organ injured in blunt injury abdomen is spleen followed by liver. Penetrating injury, somebody putting a knife in the abdomen. The most common organ injured now is liver. Second only small intestine. So first remember only one organ. So blunt injury, spleen. Penetrating injury, liver. Please don't forget one organs. Gunshot injury, somebody shooting in your abdomen. Gunshot injury, it is small intestine. I request you to remember these 3 MCQs alone for your exam. Blunt injury, you get more commonly spleen. Penetrating stab injury, liver. Gunshot injury, it is small intestine. And when you wear a seat belt injury, what organ is commonly injured? It is mesentery. Mesentery is commonly injured in seat belt injuries. So please don't forget these 4 questions. So these are the 4 questions you should not forget. Please remember this. And now I am going to show you some clinical video questions. These are actually video questions. I cannot play the video here, but what is going on in this image? So there are 3 people turning a trauma patient to one side, and a 4th fellow is going to come and examine from here. What is this examination known as? This is known as log roll examination, definite MCQ for national board exams. It is used for spine examination. Spine examination is done with the help of log roll. We need 4 people for doing this test. Okay, it is mainly for spine examination. So what is going on in this image? Second image, this image. So I am going to show you some images and I am asking you what is being done. So you can see here, this is a burr roll. This is a burr roll instrument used to make a hole in the cranium. You can see the hole is made in the cranium and we can let out the extradural hemorrhage. So this is burr roll going on here. So what is going on in this picture? There is a patient with an opened abdomen. This patient is having an open abdomen with a plastic sheet covering. This patient is having an open abdomen with another special device available. What is this? This is known as Bagota bag. So after abdominal burst abdomen, or abdomen is not able to be closed, in such cases I can use a Bagota bag, and the second one is an expected image. This is known as VAC device, video assisted closure device. Okay, it is known as video assisted closure device. This is video assisted closure device shown in the picture. So please don't forget, these are high yield MCQs. So I am going to now discuss you the typical FMG questions. I don't want you to learn like old pattern one-liners. I want you to know questions like this. This is how the questions will be framed for you in the new pattern question. Maybe the only excuse by chance the examiners may think because of the COVID situation they may ask you one-liner question. But this is the pattern of question being asked last 2 years. Mr. Ramu, 40 years, was planned for a laparoscopic hernia surgery. He was created pneumoperitoneum using this instrument. You know this very well. This is Viry's needle. So this needle is having a safety valve. What is the complication that can happen with this instrument? So please remember, Viry's needle will not injure the bowel or bladder, but it can go and injure the deeper vessels. When you go forcefully, you will go and injure the IVC injury can happen. So IVC injury is happening with very rare, but very rare. It can happen if you don't properly use it. You can go and injure it. Okay, this is IVC injury can happen with the help of Viry's. So Mr. Somo, 50 years, male, short bowel syndrome, who is on TPN. For past 3 months, he is on TPN. Suddenly developed jaundice. So he developed a jaundice. SGOT, SGPT is elevated. It means the patient is going towards liver failure. So if a patient is going towards liver failure, I told you I have to stop the TPN temporarily. And I should start fat-free TPN, and I should look for hepatic steatosis. And in such cases, I should plan for combined transplant will be planned soon. Combined small bowel plus liver transplant will be done very soon. For this is a paragraph taken directly from Bailey and Love. For a patient with the short bowel syndrome suddenly developing jaundice, the treatment is stop the TPN temporarily, restart with fat-free TPN is the answer for this question. So you should start a fat-free TPN. Okay. Sorry, the answer has already come here. So very nice question. Next question. Mrs. Kumari, 60 years female, was operated for acute cholecystitis. She developed fever on first post-op day. What is the most probable cause? So fever, post-operative fever. This is a separate topic you should know. It is discussed in many sessions. First day, what is the cause? Second day, what is the cause? Third day, what is the cause? Fourth day, fifth day, sixth day, seventh day. We have 7 days of post-operative fever, which is discussed in our materials also. So first day post-operative fever is usually due to A, B, C, D, and 5 looks like yes. 6, if you hit, you will burst, and 7 happens, you go to heaven. Remember the mnemonic. I will tell you the answer of post-operative period in each period. 1, it is atelectasis. Day 1, it is atelectasis. Day 2, it is bladder infection or UTI. 3 is catheter related, not Foley's catheter. It is due to cannula, catheters, IV catheter related. 4th, DVT. 5th day, surgical site infection is the cause of fever on 5th day. Burst abdomen, you saw the previous images of burst abdomen, no? That is the cause of fever on 6th day. And you go to heaven if there is a leak of anastomosis. So post-operative fever is a classical question for a NEET PG exam. So please don't forget the causes of post-operative fever: atelectasis, bladder infection, catheters, DVT, SSI, burst abdomen and leak of anastomosis. So you are a CRRI assisting a gal. So the answer for this question on first day is very clear. It is atelectasis of lung. So answer is B here. Okay, answer is B. So next question is a classical clinical question which you can get in exam. You are a CRRI assisting a gallbladder surgery. The senior resident asks you to retract and gives a retractor and asks you to retract the liver. Which one will you select in this? A, B, C, D. So classical liver retractor is A, that is a deverse retractor will be used. So you will be using a deverse retractor for retracting the liver. Okay. Mrs. Goyal, who had acute urinary retention, was inserted a green cord Foley's catheter, returning back after 30 days, and we are trying to deflate the balloon, but it is not getting deflated. What will you advise now? This question I just now discussed. You have to shift to ultrasound room and puncture the balloon. So answer is C. So it is a simple straightforward question. Shift to ultrasound room and put a puncture. In a mass road traffic accident, Mr. Gupta had a ulnar fracture, pulse rate normal, BP normal. Which is the following badge given to him? He is a patient with a walking wounded, so green badge. This patient will get a ticket, green badge and come to hospital. Please remember this. Mrs. Maya admitted in casualty with severe dehydration due to diarrhea. We are trying to resuscitate her with oral. What is the best cannula to infuse maximum? The question is asking maximum fluid. So maximum goes with 14 gauge. So please remember maximum goes with 14 gauge cannula. So these are all typical clinical questions. Dr. Gunal was running to blood bank to get 2 units of packed red cells, platelet to resuscitate a trauma patient. In the blood bank, they told it will take 1 hour to do cross matching. So he decides to get a blood which can be transfused for anybody. So universal blood donor. So universal blood, what is it? Which can be used for anybody. It is O negative. So in such trauma patients, we get O negative and transfuse the O negative blood. So the answer here is O negative C. Okay, universal blood. Mr. Ramanujam, Brahmin by caste, underwent a hernia surgery and now presenting 15 days after with a discharge from the wound. The surgeon used a suture for subcutaneous closure. Is a reason for this. The surgeon has used some suture which has made a wound infection. What will be that suture? That suture will be usually a catgut which should not be used in vegetarian people, though will be having an allergic reaction more. So a 55-year-old male with a complaints of bleeding per rectum diagnosed to have carcinoma colon. Nothing to be read in this question. The question is identify the instrument shown. The answer is monopolar cautery. Very straightforward, simple question. So it's a monopolar cautery. So what is the complication of putting the patient in this position for surgery? This is prone jackknife position. Prone jackknife position. The patient will develop one complication. Expected MCQ for FMG exams. This patient will develop positional asphyxia. We do operations like pilonidal sinus surgery is done in this. Pilonidal sinus operation will be done by this prone jackknife position. Okay, please don't forget this. So the next question is a definite MCQ for NEET PG, but very rarely asked in FMG exam, but this is an expected question. There is a WHO surgical safety tabular column which is known as sign in, time out and sign out. These are the 3 columns used in WHO surgical safety guidelines. In this, the question is asking 10 years after hysterectomy, patient presenting to you with the fever and loin pain. Can you see there is a missed pad seen. Missed pad which is being missed during previous surgery was seen there. So where is the problem happened in this 3? Sign in, time out, sign out column. Where is the problem happened in this means sign out is a column where they do counts. After surgery will be done in sign out column. So sign out is nothing but before shifting patient out of OT. So before shifting patient out of OT is known as sign out. Before shifting the patient out of OT, we should count the pad, needles, etc. and confirm we have not kept anything inside the patient. So the answer here is the problem happened in sign out. So this question is a high yield question. I want you guys to read about this WHO surgical safety guideline. Okay. Mr. Arnold developed RTA and presented with breathlessness. See, breathlessness, BP less than 90, JVP elevated. Please understand the catch points. JVP elevated and trachea is shifted to the left. Trachea shifted to the left and auscultation, right lung has no air entry. The right lung is having no air entry. So this is a case of a pneumothorax. Please remember, it is a case of tension pneumothorax. What should be done immediately? Immediately I should put a needle. So immediately put a 16 gauge needle in the right side mid-axillary intercostal line is true. They are asking which is false. Arrange for an ICD tube. Please remember the needle insertion is a first aid. Immediately you should also put an ICD within half an hour. So ICD will also be put. Heimlich valve is used. Heimlich valve is used. There is a special valve known as Heimlich valve can be used for pneumothorax. E-fast is not useful for the diagnosis. If you have attended the class clearly, you can answer, sir, E-fast I used. What sign I found in E-fast in a pneumothorax? I found a barcode sign. So E-fast is useful. It is not useful is wrong. E-fast is useful for the patients. Okay, that's the section A. We have completed the general surgery and trauma. We are now moving on to the next section on head and neck, thyroid, breast and hernia, important points. So the most important thing I want you to know is about this dissection. Can you see there is a major surgery which has been done in this patient in the neck. So this surgery is what we call it as radical neck node dissection. I am going to explain about this radical neck node dissection now. So can somebody tell me how many levels of neck nodes we have? How many levels of neck nodes we have? This is sternocleidomastoid muscle, this is clavicle, this is neck. So we have 7 levels of neck nodes. Level 1 is submental submandibular. Submental submandibular is level 1. Level 2 is upper jugular. Level 3 is middle jugular. Level 4 is lower jugular. Upper, middle, lower. Okay. Then 5 is posterior group of nodes. 5 is posterior group of nodes. 6 is MCQ for FMG exam. Please don't forget 6 is pre-tracheal and pre-laryngeal nodes. Can you tell me what is the name of pre-laryngeal nodes? It is known as Delphic nodes. So 6 is known as pre-tracheal and pre-laryngeal nodes. It is Delphic nodes. And 7 is upper mediastinal nodes. In a radical neck node dissection, I will be removing the nodes from 1 to 5. See in the picture I have removed level 1 submental submandibular node removed, upper jugular, middle jugular, lower jugular removed, posterior group of nodes removed, 1, 2, 3, 4, 5 nodes removed, but I have not removed. And also I have removed in this, you can see, I have removed the submandibular gland. What else I will remove? Submandibular gland is removed. I also removed, very important, please remember, part of parotid gland is removed. And along with this, in this image you can see I have removed SIS. Please remember, SIS is the MCQ for FMG exam. What is SIS? Sternocleidomastoid muscle removed in this image. Internal jugular vein removed. Spinal accessory nerve removed. These 3 important structures are removed. Sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve. All these structures are removed in radical neck node dissection. I have removed all these structures. What is that? And then I have preserved in a radical neck node dissection. I have preserved carotid artery. You can see I have preserved a carotid artery. I have preserved vagus nerve. I have preserved lingual nerve. I have preserved hypoglossal nerve. That's all. Everything else in the neck I have removed. From the picture itself you can see everything else I have removed. Carotid artery, vagus nerve, lingual nerve, hypoglossal nerve. That's all. Everything else I have removed. The preserved structures are these 4. So this is an essential question for your exam. I have written this here in the type it also. So please don't forget what are the structures removed and what are the structures preserved in radical neck node dissection for neck secondaries, neck node secondaries. So what is the surgery known as modified radical neck node dissection? MR&D, everything is same. Everything is same except I will preserve SIS. This is FMG question. In modified radical neck node dissection, what are the structures preserved apart from the structures preserved in radical neck node dissection? It is sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve are the structures removed and preserved in MR&D. So with this concept you can answer most of the questions in oral cancer. So oral cancer, if at all the examiner wants to do a question, they will always put question like this: sternocleidomastoid muscle, internal jugular vein and spinal accessory nerve. So Maria Doc Nix, I have already uploaded the rapid revision for FMG for 5 hours. I have uploaded in my YouTube channel. Already it is available. You can see that videos. It is already available in YouTube. In my channel it is available. So this is a picture showing you a commando operation. This image looks very bad. No, it is commando. Commando means combined mandible and neck node dissection. This is a picture showing you combined mandible and neck node dissection operation. That is what commando. So neck node dissection operation is shown in the second image. So this is a picture showing you the pleomorphic adenoma. I am going to tell you 5 questions from pleomorphic adenoma. This is the most common benign tumor of parotid gland. Okay, it is most common in females. It is most common in females. It is a most common tumor of parotid gland. It is most common in tail of parotid gland. It usually arises from the tail. This is a parotid gland. This is a parotid duct. I hope you know the name of the parotid duct. The name of the parotid duct is known as Stenson duct. The pleomorphic adenoma arises from the tail of the parotid gland like this, and therefore it lifts the ear lobule. Okay, it lifts the ear lobule, and treatment is parotidectomy. It needs parotidectomy. So the second picture is showing you a tumor at the lower pole. This is known as Warthin's tumor. So Warthin's tumor is exclusively seen in parotid gland. It doesn't happen in other glands. It is exclusively seen in parotid gland. It is most common in males. It is most common in smokers. This question is a high yield MCQ for your FMG exams. In FMG exam, they will ask you questions from Warthin's tumor commonly. It is most common in males. It is most common in smokers. It presents at the lower pole of parotid gland. Please remember, it is seen most commonly in the lower pole of parotid gland. So previously I told you it is seen at the tail. This is where the Warthin's tumor is seen, at the lower pole of parotid gland. And very interesting MCQ is it appears as hot spot in technetium 99M scan. This Warthin's tumor appears as hot spot, and it is 10% time bilateral in patients, and treatment is enucleation is enough, no need of parotidectomy. So this is a 2 important tumors you must know for your exams, especially in the last minute. The FMG examiners, they always ask question from pleomorphic adenoma or Warthin's tumor, and more from Warthin's tumor. This is a tumor common in males and smokers. It is 10% time bilateral, and it appears as hot spot in technetium 99M scan. Please don't forget this Warthin's tumor for your exams. So you can see the picture showing you the parotidectomy being done. This is a picture showing you parotidectomy being done. This is a superficial parotidectomy shown here. Superficial lobe of parotid is removed, and superficial parotidectomy completed, and you can see all the branches are very carefully preserved. And now one of the important complication I want to tell you here is most common nerve injured in this surgery. Can somebody tell me what is the most common nerve injured? I am going to tell 3 questions. 1, 2, 3 from parotidectomy surgery. Most common nerve injured is branch of facial nerve. Some branch of facial nerve is the most common nerve injured. Most common cutaneous nerve injured. What is it? Because facial nerve is a motor nerve, it will not cause any sensory loss. So what is the most common cutaneous nerve injured? Can somebody tell me what is the most common cutaneous nerve injured? This question is the last year NEET PG question. They will be asked. The question is asking after injury of this cutaneous nerve, you will have paresthesia in the shaving area. Paresthesia in the shaving area is because of greater auricular nerve. So Yogesh, this PDF will be shared in the surgery 6er group, don't worry. And Puneet Chardon's greater auricular nerve is the most common cutaneous nerve injured, not the most common nerve injured. And Karthika, the diagnosis of pleomorphic adenoma is by FNAC. It is by FNAC we diagnose the pleomorphic adenoma. Okay, we should not take biopsy, but we can take FNAC. So most common nerve injury that is causing Fraze syndrome. What is the injury that causes Fraze syndrome? I hope you know Fraze syndrome is nothing but gustatory sweating. What nerve is injured in this? The nerve injured here is auriculotemporal nerve. So it is an auriculotemporal nerve injured is Fraze syndrome here. Postganglionic parasympathetic nerve is injured. So please remember, auriculotemporal nerve, postganglionic parasympathetic nerve is injured. That is auriculotemporal now. So that is the picture showing here. The patient had a Fraze syndrome. He is doing a test known as starch iodine test, is the investigation of choice. And after that test, the treatment is going on here. What treatment is going on here? The treatment going on is Botox injection is being injected. So Botox injection is a treatment for Fraze syndrome. So Fraze syndrome is a definite MCQ for FMG exams. So please don't forget that Fraze syndrome is due to injury of auriculotemporal nerve. Okay, auriculotemporal. Yes, that is Shiva, that is correct. The surgery paper leak is for NEET PG, not for FMG. Surgery paper leak is for NEET PG exams. You can use that. This videos you can use for FMG. This is a fast rapid revision. Only 10 more days. This is best for you. So the last image from this section, this topic is ranula. Can you see? This is a ranula, which is a extravasation cyst. Please don't forget, ranula is an extravasation cyst of sublingual glands. Please don't forget, ranula is an extravasation cyst of sublingual gland. Plunging ranula is a retention cyst of sublingual or submandibular gland. Okay, retention cyst is plunging ranula. Ranula is extravasation cyst. They both are excellent. Transillumination will be seen. So transillumination will be excellent in both the cases. So excellent transillumination will be seen in these cases. So this picture is a classical FMG question. You can see this picture showing you a mass in the neck. It is a potato tumor. Okay, it is a potato tumor known as chemodectoma, also known as carotid body tumor. It is also known as carotid body tumor. Very common in middle-aged females living in high altitudes. You are seeing a sign here on angiogram. What is this sign? What is the name of this sign? That is the question asked here. So this sign is known as Lyre sign. Lyre sign. Please don't forget, this sign is Lyre sign. Okay. So this point you should not forget. This is a Lyre sign. Yes, this video will be uploaded in dr.raja's app. You can see that. Don't worry. Very good, Maria. That's correct. That is Lyre sign. So the Telegram group where you can download this PDF will be Telegram Surgery Sixer. Okay. This is a Telegram group where you can download this PDF what I am writing in the class. You can download the PDF of this class here, and the videos can be watched in dr.raja's app. Dr.raja's app, FMG, that all the videos which are being taken is available for you free. Okay. So the next picture is showing you a classical picture showing you, this is sternocleidomastoid muscle. Can you see there is a bony swelling on the posterior triangle? Bony swelling, what is it? On the posterior triangle you can see a bony swelling that is known as cervical rib. That is a cervical rib. You can see a cervical rib. That cervical rib. So that cervical rib can compress the subclavian artery and can cause a syndrome known as thoracic outlet syndrome. And that has caused gangrene of the fingers. Can you see the girl has developed a gangrene of the fingers? So there is a typical thoracic outlet syndrome, and the commonly done test for this is this test. This test can be coming for your example as a clinical test. You ask the patient to turn to the same side, extend the neck and palpate for radial artery. The radial artery pulse decreases. What is this test? This is a 100 times asked MCQ. Please don't forget, this is Adson's test for thoracic outlet syndrome. Please don't forget, this is 100 times asked MCQ. Thoracic outlet syndrome for Adson's test. Okay. So NEET PG, there may be a session for you also in dr.raja's, but we have already our rapid revision videos uploaded in dr.raja's app. Also we have around 20 hours videos for surgery, and if you want a fast revision you can use a question paper leak from my channel. So this question is a high yield MCQ again. For FMG exam, this question can come to you definitely. This is radioactive iodine uptake study. So the commonly used substances are iodine 131 and iodine 123. Iodine 131 half-life is 8 days. Iodine 123 it is 12 to 14 hours only. So iodine 123 is used for diagnostic purposes. Iodine 131 is used for therapeutic purposes. Please don't forget, it will be used for therapeutic purpose. Diagnostic 123, 131 is used for therapeutic purpose. So this is a radioactive iodine study. They are used for diagnostic as well as therapeutic. For your exams, they will ask you what are the therapeutic uses. Therapeutically, it is used for Graves' disease, to reduce the thyroxine production in Graves' disease and to destroy the mets. These are the main two therapeutic uses of iodine 131. We can use it for destroying the tissue and destroying the mets. So it is diagnostically used to find out whether it is a hard or cold nodule. So now the hard nodule name is changed as warm nodule. So warm nodule is, this is a picture showing you cold nodule. Cold nodules are 20% malignant, and warm nodule is a nodule which is having increased activity 5% malignant. It is also helps to diagnose Graves' disease. You can see this is a Graves' disease which is having increased uptake. So increased uptake is seen in this. It's a Graves' disease. So nodular goiters, you can see the nodules which are all hard nodules which are due to increased uptake. So it is used for diagnostic and therapeutic. Radioactive iodine uptake study is an expected MCQ for your exam. It is contraindicated in children and pregnancy. It should not be used in children and it should not be used in pregnancy. Please don't forget this MCQ. So radioactive iodine uptake study for exam is essential. So this is a picture. It is used to diagnose the mets. You can see multiple mets, and we can ablate the mets with the high doses. With the radioactive iodine, we can ablate the mets with the high doses. We can ablate the mets also. So this I am showing you certain tests which are highly expected MCQs for your exams. What is this sign shown in this girl? So this girl is doing one test. So this girl is doing a test known as Pemberton sign. When you suspect retrosternal goiter, so she is doing a retrosternal goiter, we are doing a Pemberton sign. Welcome Shishan. So this is a retrosternal goiter. Pemberton sign is shown in the first image. The second sign is Piscillo test. This is a Piscillo's test for a short neck individuals. So this is a 3-finger examination of thyroid known as Lahey's test. Actually all these questions can be asked as a small video. GIF video they can ask you. So this is Lahey's test in which 3 fingers used to push and examine with the 3 fingers. This is with a single finger, that is with a thumb I will palpate, that is Kreil's test. So all these are expected MCQs, okay, it's Kreil's test. So this is a picture showing you pretibial myxedema. Who will get this? Pretibial myxedema is a feature of pretibial myxedema, acrobachi, and eye signs like this, exophthalmos. All these are seen in Graves' disease. All these are seen in Graves' disease. So please don't forget, in Graves' disease all these signs are seen. Pretibial myxedema, acrobachi, exophthalmos, and all the eye signs you can see in Graves' disease. So this is a classical image video. They will again ask in exam. The patient is protruding the tongue out. On protruding the tongue out, the swelling is moving upwards. This is a typical picture showing you thyroglossal cyst. So expected MCQ for your exam. The thyroglossal cyst can get converted to what malignancy? What malignancy can you expect in thyroglossal cyst? The malignancy expected is papillary cancer can happen in thyroglossal cyst. Papillary cancer is a malignancy expected in thyroglossal cyst. Please don't forget, papillary cancer can arise from thyroglossal cyst, and the treatment done for thyroglossal cyst is cyst trunk operation. Cyst trunk operation is done for thyroglossal cyst. Please don't forget cyst trunk operation. So now I am doing an FNAC for a thyroid swelling. I am getting as two features. What are these 2 features? Highly expected pathology based surgery questions. The first one is orphan Anni eye nuclei. Orphan Anni eye nuclei is shown in this image. Can you see? It is an empty nuclei. The second one is Samama bodies. These are seen in papillary cancer. Very important MCQ. They are seen in papillary cancer. You get these appearances. Okay. So this is a highly expected NEET PG question. FNAC shows amyloid stroma. Where will you get this? A thyroid neoplasm. We are doing an FNAC that shows amyloid stroma is seen in medullary cancer. Medullary cancer is a familial cancer seen in men 2A, men 2B cases. Men 2A and men 2B patients, they will get medullary cancer. Therefore, I should advise them prophylactic thyroidectomy. Prophylactic thyroidectomy is done for these patients with the men 2A and men 2B syndromes. We should do prophylactically, we should do thyroidectomy for these cases. The last important cancer is Anaplastic cancer which happens due to P53 mutation, very common in old age. They die within 6 months. Mortality seen in 6 months. So anaplastic cancer is a very worst cancer. Okay. So now this question is a highly expected MCQ. There are various types of thyroidectomies I am showing you. This is lobectomy. This is subtotal thyroidectomy. In subtotal thyroidectomy, how many grams left? 8 grams is the latest Bailey value. Should be left on both sides. So on both sides I should leave 8 gram this side, 8 gram this side. So this is subtotal thyroidectomy, and this is near total thyroidectomy where I will leave 2 to 4 gram one side only. So 2 to 4 gram only one side is known as near total or Dunhill operation. So it's near total or Dunhill operation. So follicular adenoma and Maria Khan, follicular adenoma and carcinoma cannot be differentiated. Once you get a picture of follicular adenoma or follicular neoplasm in FNAC, we should go for thyroidectomy, and based on the thyroid specimen only we will decide whether it is a cancer or benign. Okay, that is cannot be diagnosed by FNAC. So subtotal thyroidectomy 8 gram on both sides. Near total only 2 to 4 gram on one side. So the next question is a clinical question. Clinical FMG question. You are house surgeon working in a ward. You are going for a evening rounds. A patient is having gasping. There is a huge hematoma in the postoperative neck. What you should do immediately? You can see this is a neck hematoma. I should immediately let out the hematoma. Let out the hematoma is the answer for this. So I should let out the hematoma bedside. Bedside I should let out the hematoma. Please don't forget this point. This is a clinical question which you can expect in exam. So this is again a very important clinical question. On a third day you are going, third to fifth day you are going for a ward rounds. The PP is measured by the house surgeon. The hands are going for a spasm like this. It is nothing but Trousseau sign. This is a Trousseau sign. When you tap in front of the face, they will have Chaustuck sign. So Chaustuck sign and Trousseau sign are features of occult hypocalcemia. Occult hypocalcemia will get these features. So please remember Chaustuck sign and Trousseau sign. Immediately I should give oral calcium for occult hypocalcemia, and overt means the patient already in tetany. The patient will be in tetany. I should immediately put IV calcium gluconate. So the SWOT says if there is a mild symptom, we can just give oral calcium itself. If there is severe tetany seen, already patient is in spasm, you should give IV calcium gluconate. This is a line directly from SWOTs. So high yield MCQ for your exams is breast cancer. I request you guys please know the breast cancer stagings, and in T1, T2, T3, T4 is a high yield MCQ topic for your exams. I want you to know everything about T4. T4A is nothing but chest wall involvement. The tumor has gone to the chest wall is known as T4A. Can you tell me what is T4A? The tumor involves, number 1, it is involving the ribs. It involves intercostal muscles. It involves serratus anterior. It is known as T4A, serratus anterior. T4B, the tumor involves the skin over the breast. That is 1, pute d'orange. What else? Pute d'orange is skin involvement. Number 2, ulcer in the skin is skin involvement. Satellite nodules is skin involvement. T4C is both above. T4D is inflammatory breast cancer. So please don't forget T4. Usually they ask questions for your exams. What is T4A? T4A is chest wall. T4B is skin. Everything is there in the material. I'm just focusing which is more commonly asked in exam. T4C is both. T4D is a very rare cancer, inflammatory cancer. These are pictures showing you T3 lesions. T3 lesions are more than 5 centimeter lesions. So this question is a repeat question. If a patient is presenting to you like this with a pute d'orange, can you see the pute d'orange? Looks like an orange skin. It is a pute d'orange. If there is pute d'orange seen like this, it comes under T4B. Okay. These are the patients who are having skin ulcerations. Can you see the ulcerations? They come under T4B. This lady is having a chest wall involvement, that is T4A. So like that you should be knowing to know that T4 staging. Usually they ask questions from T4. So this is a picture showing you a modified radical mastectomy specimen. This is a picture of modified radical mastectomy specimen, and this is an axillary node dissection done. So axillary node dissection boundaries they may ask you in your exams. So this is an axilla. So modified radical mastectomy, I should remove the nipple, areola, entire breast tissue. Along with that, I should also remove the nodes in the axilla. Minimum nodes that should be removed is how much? Minimum 10 nodes should be removed for your complete surgery. So please remember, minimum 10 nodes should be removed. The boundaries are superiorly by axillary vessels. Superiorly we have axillary vessels. Medially we have nerve of bell. Laterally we have thoracodorsal pedicle. So actually this is a Ames question, just for completion I am telling you. Thoracodorsal pedicle, and inferiorly we have angular vein. So what are the boundaries of axillary dissection is a repeat Ames question. For FMG exam they will ask you the minimum number of nodes that should be removed will be asked in exam, minimum 10 nodes, and what are the structures preserved in MRM they will be asking you. Preserved structures are remembered as A, B, C, D and M. A for axillary vessels. What are the structures preserved in MRM or axillary vessels? Bell's nerve, cephalic vein, nerve to latissimus dorsi and pectoralis major. Okay, pectoralis major muscle. So nerve to latissimus dorsi, pectoralis major are the structures preserved in MRM. So please don't forget this thing. Okay, this is very important for your exams. Dinesh, lobular cancer in situ and ductal cancer in situ are cancers which are not involving the membrane. They are not involving the membrane. They are not involving the basement membrane is known as lobular cancer in situ. So can you see here the boundaries very clearly? You can see this is pectoralis minor, this is pectoralis major, this is thoracodorsal pedicle, this is axillary vessels. Every boundary is seen in this. This is an axillary dissection. This is a definite MCQ for your exam. What is going on? What is going on in this and this? There are two images I am showing you. What is going on in those two images? So in the first image you can see we are injecting methylene blue and we are catching the blue color node. Second image we have injected radio labeled colloid and using gamma camera to catch the node which is having highest radioactivity. These two procedures are known as sentinel node biopsy for cancer. Sentinel node biopsy of cancer breast is these two images showing you the sentinel node biopsy. So please don't forget, this is an expected MCQ. This is a sentinel node biopsy for cancer breast. This is using methylene blue. The second one is using radio labeled colloid. So some images are very commonly asked in exam I am seeing in our recent days. So this is a picture showing you an umbilical hernia in a child. Umbilical hernia in a child surgery can be delayed up to 2 years. Bailey says up to 2 years we can postpone the surgery for children. And this is adults. The defect is up to 2 centimeter may be sutured. So this is an adult patient with a umbilical hernia. We have to do suture or we have to keep a mesh. So this is an epigastric hernia which happens in the linea alba. So please remember, so linea alba, through that the pre-peritoneal pad of fat. Please understand, the pre-peritoneal pad of fat will come out of the linea alba. It is known as epigastric hernia. So this is an epigastric hernia. These pictures are put only for image based purposes. So this is an incisional hernia. You can see previously some scar is there. Through that scar the hernia is coming out. This is an incisional hernia. Please don't forget this. So most important, recently the FMG examiners they started focusing towards the laparoscopic anatomy of hernia also. So please have an idea about the two triangles I am going to show you now. Triangle of doom and triangle of pain. Only two triangles I want you to know. Just remember the diagram I am drawing. So this is iliopubic tract. So this is a iliopubic tract. Iliopubic tract. This is a deep ring. Okay, this is a deep ring from inside. I am now seeing the canal, inguinal canal from inside. This is peritoneum. Okay, I am seeing from inside. I am seeing now from inside. This is a deep ring seen, and into the deep ring I am seeing the vas deferens is entering. This is vas deferens. And this is gonadal vessel, testicular artery and testicular vein is entering. So this is known as gonadal vessels are entering. And this is the reflected part of peritoneum. You can see this is the reflected peritoneum. Inside this the bowel, everything is present inside this. So now you can see I have made the anatomy already is over. The anatomy of triangle of pain and triangle of doom is over. So see, there is a triangle here. bounded by vas deferens, gonadal vessels. It is known as, what is this? This is known as triangle of doom. So this is a triangle of doom containing external iliac artery, external iliac vein. Please remember that will be external iliac vein and external iliac artery inside this triangle. So this is triangle of doom. This is a triangle of doom bounded by external iliac artery. So external iliac artery and external iliac vein are content, bounded by vas deferens, gonadal vessels and reflected peritoneum. Please remember. The next one is triangle of pain. This is a triangle of pain. So this is bounded, already you can see the boundary. It is bounded by iliopubic tract, reflected peritoneum and gonadal vessels. So it is containing 4 nerves. There are 4 nerves inside. That is why it is known as triangle of pain. Ilioinguinal, the nerves which are seen here inside are femoral nerve, lateral cutaneous nerve, genitofemoral nerve, femoral branch of genitofemoral nerve and lateral cutaneous nerve and anterior cutaneous nerve are the 4 nerves seen. So these are the 2 triangles once a laparoscopic surgeon is doing a surgery should be focusing. The most common nerve injured in laparoscopic surgery, what I have drawn here is there in this image. So what I have drawn is much easier to understand than this image. In this image you can see this is iliopubic tract, this is gonadal vessels and you can see all the nerves inside. So typical all the nerves are inside. Most common nerve injured in laparoscopic surgery is lateral cutaneous nerve. Laparoscopy LCN, remember like that. L for L. In a laparoscopy, lateral cutaneous nerve is injured in a hernia surgery. So now let me show you the latest pattern questions for this syllabus, for this section. A patient presents with a thyroid swelling. Okay, thyroid swelling, weight loss. The physician found presence of cervical node in the same patient and decided to go in for a thyroid biopsy. Histopathology suggested orphan anenuclei. So the answer is clear, orphan anenuclei, papillary cancer. So any clinical based question will have a catch point. You have to catch that point. So don't waste your time reading full question. Sometimes there will be a catch point you can find out in a single line. So this is a typical papillary cancer. So this is a last year question for you. 45-year-old male came for post-surgery follow-up. Yes, chest X-ray was done. What is the diagnosis? Can you see? This is a breast shadow. Right side breast is seen, left side no breast is seen. So that is a post-mastectomy, left-sided mastectomy case. Simple case. Left-sided mastectomy. If you observe very closely, you would have answered this. It is not a lung, it is a left mastectomy image. This question came last year. Okay. So that is a question from last year 2019 question. 55 years female underwent mastectomy. Immunohistochemistry showed estrogen receptor, progesterone receptor positive, HER2 negative. What is the molecular classification? So I never expected this type of questions will come for FMG exam, but this question is the first time it has came. Molecular classification is divided into luminal A type, B type, HER2 type, basal type. I will make you very simple. It is very easy to remember. So there are 3 markers should be seen. Estrogen receptor, progesterone receptor, HER2. You have to see whether they are positive or negative. Luminal A is the most common type. Please remember. So most common type will have ERPR positive, HER2 negative. Therefore, this is the best prognosis. ERPR positive, HER2 negative is best prognosis. And coming to B, I will tell you easy method to remember B. B means B positive always. B positive. So it is all positive. When you are always negative, you go to base. So all negative is basal. HER2 will be only HER2 positive, all others are negative. Simple concept. So only you should remember luminal A. Luminal A is common type, ERPR positive, HER2 negative. So answer is luminal A type is the answer for this question. So please don't forget molecular classification of cancer breast. I would have not discussed this if it has not been in a previous exam. Dr. Gupta, a famous laparoscopic surgeon, is doing a lap hernia. He used tackers while fixing the mesh. Patient is complaining of pain in the post-operative period. What is the most common nerve that he would have injured? What is the most common nerve? The answer is already told. LCN, lateral cutaneous nerve, is the most commonly injured nerve in a laparoscopic surgery. A patient operated for paroidectomy developed pain and erythema in the side of face with a sweating at the time of eating. Which of the following is wrong about this phrase syndrome? Simple question. So nothing, they have converted all the one-liner questions into clinical questions, that's all. Otherwise, don't get scared of the clinical question. They are nothing but simple one-liners which are asked past 2 years or past 10 years. They simply made it as clinical question. So phrase syndrome, which is wrong? The question first line itself is clear. Post-ganglionic sympathetic nerve is injured is wrong. It is post-ganglionic parasympathetic nerve which is injured, which is auriculotemporal nerve. It is not sympathetic nerve. It is post-ganglionic parasympathetic. So that is the wrong answer. So it is treated by Jacobson's neurectomy. Old treatment is true. Starch iodine test is used true. Can be prevented by keeping a sternomastoid flap is also true. So the answer is very clear. The first answer is Pakka answer. It is not sympathetic. It is parasympathetic nerve injured and phrase syndrome. So now coming to my area of GIT. So we have completed around 40% of the syllabus. So this question is showing you a clear-cut image, 100 times asked question. I will put the question image. I will ask one question and treatment. This is a picture showing you bird's beak appearance. Where will you get this? This is a picture shown in Achalasia cardia. It is seen in Achalasia cardia. The treatment is modified Heller's cardiomyotomy. Modified Heller's cardiomyotomy is the treatment for this, and recent treatment for this is POEM, peroral endoscopic myotomy is the latest treatment for these cases. So this is a fast one-liners. Just observe the picture, know the concept, tell the treatment. That's all. So what is this? This is a barium swallow. All these are barium swallow images showing you an appearance like this. It is a corkscrew esophagus. Where is it seen? It is seen in diffuse esophageal spasm. It is a motility disorder. It is seen in diffuse esophageal spasm. Okay, please don't forget, this is seen in diffuse esophageal spasm. You get this image. So yes, very good. That is the corkscrew esophagus. Perfect. Yeah, that is a diffuse esophageal spasm. I am expecting this question for your exam this year. What is this investigation? This question I am expecting this year. Thank you, Vishal. Thank you. So what is this investigation shown here? This is a high resolution manometry. I am expecting this question for your exam this year. High resolution manometry. The investigation of choice for motility disorders. Investigation of choice for motility disorders of esophagus is this. This is high resolution manometry. You will get this question in your exam, no doubt. So the next question is showing you a girl having something tied in the hip, and there is, you can see a small catheter entering her nose. Can you see some catheters entering in her nose? So this is classically a picture showing you one test is going on. The gold standard test for GRD. What is it? Gold standard test for GRD is 24 hours ambulatory pH monitoring test. This girl is undergoing a test known as 24 hours ambulatory pH monitoring. Very good, Manjusha, very good. So this is a 24 hours ambulatory pH monitoring is going on. The score derived from this is D Meister score. When it is more than 14.7, definitely there is a GRD. So this is a D Meister score, more than 14.7, that is GRD. So can you tell me what is this image showing you? This image is showing you a barium swallow with a ring here. Endoscopy shows that ring here. It is a submucosal ring. What is this? Seen in GRD patients known as Skatsky ring. Skatsky ring. So this can be easily treated by dilatation. Dilatation is a treatment for this type of Skatsky ring. Okay. So this question came in the exam. That is why I am putting this question from GIT, from Bailey and Lau. This nerve, what is this nerve? That is a question shown. From the posterior vagus nerve, there is a nerve going to the fundus. What is identify the name of this nerve? The question came in your exam. That is criminal nerve of Grassi. Criminal nerve of Grassi. This question has been a repeat question for FMG exams. So please don't forget, from the posterior vagus nerve, the branch supplying the fundus is known as criminal nerve of Grassi. Next, you are seeing an organism, that is Helicobacter pylori. The culture medium for this organism from microbiology. What is the answer? The culture medium is scirrhous medium. Okay, the culture medium is scirrhous medium. And what is this type of flagella seen? What is this flagella seen? It is a lophotrichous flagella, multiple flagella on one side. It is a lophotrichous flagella, multiple flagella on one side, not short gastric bar. That is a criminal law of Grassi. So this is a lophotrichous flagella, multiple flagella seen on one side. And please don't forget the culture medium is scirrhous medium. The stains used are Giemsa stain, So I think it's back now. Please see the video. I think it's back. There is some small internet connection problem. I think it's back now. Yes, now it's fine, Sony. Yes, please now follow this. Just what I told you in this buffering time is only one. I told you about the treatment of this duodenal ulcer perforation. I told you about the duodenal ulcer perforation. For a patient with a duodenal ulcer perforation, 70% of the time it is diagnosed with X-ray, 30% time it is not diagnosed. Investigation of choice is CT scan, 100% sensitive. The treatment of duodenal ulcer perforation is I have to do laparotomy, lavage, and I have to keep a omental patch closure. That is, this question can come for your exam. The omental patch closure operation is known as Graham's omental patch. Okay, so Graham's omental patch closure. Previously, I think I told you the stains used for H. pylori: Giemsa stain, Warthin stain, silver stary. The stains used are Giemsa, Warthin, silver stary. These are the stains used for H. pylori. Okay, so there is a classification shown here. Let me see how. What is the name of this classification of cancer stomach? These are my patients operated. What is the name of the classification shown in these pictures? This is a classification of cancer stomach by endoscopy known as the Borman classification. Borman type 1 is polypoidal type of growth. Type 2 is ulcero-proliferative growth. 3 is ulcerative growth. 4 is linitis plastica. This growth is known as linitis plastica or leather bag like growth. It is leather bag like growth. So this is Borman classification, not Johnson. Johnson is from this thing. Okay, Johnson is for gastric benign ulcers. They won't ask that for your exam. They will ask you this Borman classification can be asked in your exam. So please remember Borman classification of Borman's macroscopic classification of gastric cancers. Gastric cancer. Okay, this is for gastric cancer. There is one more classification of gastric cancer. Can somebody tell me what is other classification? There is one more classification. I hope you know that. Lawrence. Lawrence is a microscopic classification. It is only two types. What are the two types? This question can come for FMG exam. It is of two types: diffuse gastric cancer and intestinal type of cancer. Diffuse gastric cancer and intestinal type of cancer are the two types of cancers. Diffuse cancer is a cancer which involves most commonly in young females. Most common in young females. It runs in families due to genetic mutation. Can somebody tell me what is a genetic mutation seen in diffuse gastric cancer? This is an FMG question from pathology. It is E-cadherin mutation seen. Please don't forget, E-cadherin mutation is seen. Intestinal type is most common in old age and it is associated with the environmental risk factors. Environmental risk factors are the causes of intestinal type, and diffuse type has worst prognosis. Most of them die. And how to differentiate because of the presence of a cell in diffuse gastric cancer? What is this type of cell known as? The nucleus is pushed to one side. So this is known as signet ring cell. This is known as signet ring cell seen. The nucleus is pushed to one side, known as signet ring cell. Okay, this is signet ring cell. Please don't forget this. And they spread by lymph node mets. They spread by lymph node mets and they spread by peritoneal mets. These are common in diffuse type. Peritoneal mets and lymph node mets are common here. In intestinal type, the mets which is common is hematogenous mets are common. So please remember, this classification is very frequent question of a NEET PG exam. So I want you to remember this classification also. So hematogenous mets are common in intestinal type and diffuse type will have lymph node mets. So now some images for your exam. What is this image showing you? A cancer stomach patient coming to you with this known as Sister Mary Joseph nodule. So this is a picture showing you Sister Mary Joseph nodule, classical image. And this is an image of cancer stomach patient having a bilateral ovarian mets. This is known as Krukenberg's tumor. Krukenberg's tumor. Bilateral ovarian mets known as Krukenberg's tumor you are seeing here. So this question is again a favorite question of FMG exam. 4 weeks baby brought by her mother with a history of non-bilious vomiting. Classical point. Non-bilious vomiting. The mother is bringing a baby to hospital. On examination, you are noting a visible gastric peristalsis present and you are seeing a mass. There is a mass present which is appearing and disappearing. So what is this case? This is a case of congenital hypertrophic pyloric stenosis. This is a case of congenital hypertrophic pyloric stenosis. Very good. The treatment is what? What is the treatment? Immediately, the moment you diagnose these cases, you have to go for Ramstad's pyloromyotomy. Ramstad's pyloromyotomy is a treatment for this case. Okay, this is a typical baby with a non-bilious vomiting. That's a catch point. Non-bilious vomiting. If there is a bilious vomiting, you should think of these two problems. What are these problems? Bilious vomiting in a newborn baby. The first one is having triple bubble. The second one is having double bubble. So first one is having triple bubble appearance. Second one is having double bubble appearance. So this is a jejunal atresia. This is a picture of jejunal atresia. Second one is a picture of duodenal atresia. Okay, please don't forget these pictures. Duodenal atresia. These are very classical radiology images you can get from exam. So this is again a classical question from surgery. So what is this case? The stomach is full of hair. This is known as trichobazar. Very common in psychiatry patients. Common in psychiatry patients. They eat the hair and that causes gastric outlet obstruction. This is a typical trichobazar. Okay. So these are again the questions of investigations. I want to tell you, this is a classical investigation you would have seen. This is known as barium meal follow through. Radiology questions only. I think this would have been discussed. A patient drinking a barium that is going inside the jejunum and jejunum is showing you bird's feather appearance. Can you see the bird's feather appearance is seen in jejunum? In this university, this is like barium meal follow through, but what is this? This is a picture showing you a tube is inserted in the jejunum. This is known as enteroclysis. This is known as enteroclysis. There is a tube inserted in the jejunum and you can see the contrast inside directly the jejunum. Here the stomach and all is seen. No, here it is not seen. So this is the latest investigation of choice for bowel. So what is this finding? What is this finding in the jejunum? What is this? There are some appearance like this. No, what is that? Known as in the jejunum. They are known as walls of Kerckring. So walls of Kerckring are features of jejunum. Bird's feather is also a feature of jejunum. So these are all classical features you should know. And what is this investigation? The next investigation, what is this? You can see the colon is studied with the help of this. This is double contrast barium enema. Double contrast barium enema is shown in this image. You can classically see double contrast barium enema. Yes, very good, Pradeep. That is also known as valvular conniventis. Very good. Valves of Kirkering or valvular conniventis, both are same. That's correct. Not hastration. Karthika, hastrations are seen in colon. Can you see the hastrations here? These are hastrations. So don't get confused with the hastrations and Kirkering. Hastrations are features of colon. They will be like this. Kirkering will be having a valves like this. Okay, don't get confused. So this is a double contrast barium enema. Air as well as barium is used. So two contrast used, air and barium. That is double contrast barium enema. So what is this? This question I am expecting this year as an image based question for your exam. This is a typical picture showing you capsule endoscopy. This is having a battery with an 8 hours battery. It can have a small battery, 8 hours. The patient has to swallow that capsule. It will start taking photograph of small bowel, mainly used for small bowel study. There is only one complication. What is that complication? With this capsule, there is only one complication. The capsule can get obstructed in the small bowel. That is known as retention is the only complication. Otherwise, there is no complication with this capsule endoscopy. Very costly investigation used in selected places. Okay. So, high yield MCQ. There has been this question for every year in FMG exam. What is the diagnosis? This is nothing but the small bowel showing you Meckel's. This is Meckel's diverticulum. So Meckel's diverticulum is found on anti-mesenteric border. Please don't forget, it is found on anti-mesenteric border. This is a mesentery. It is found on anti-mesenteric border. It is seen in 2% individuals. It is 2 inch in length. It is seen 2 feet proximal to ileocecal junction. It is seen 2 feet proximal to ileocecal junction. So 2% individuals, 2 inch in length and 2 feet proximal to ileocecal junction. This is seen. So this is a typical Meckel's diverticulum. You can see the picture showing you the Meckel's diverticulum, and this in this image has gone for gangrene. Meckel's has gone for gangrene because of twisting. Because of twisting, it has gone for gangrene. The most common presentation of Meckel's is bleeding. Most common presentation of Meckel's is bleeding in children as well as overall, and obstruction in adults. Okay, so please don't forget, these are all classical images. So this question is again a repeat question for FMG exam. This is a sigmoid colon showing you one interesting appearance. What is this appearance? It is known as sawtooth appearance. Can you tell me where will you get sawtooth appearance? In a barium enema showing sawtooth appearance is seen in sigmoid diverticulosis. This is a picture showing you sigmoid diverticulosis. So please don't forget, this is a sigmoid diverticulosis showing you sawtooth appearance. So this question is again a classical image based question from small bowel. That is a picture showing you an appearance. What is this? These are cobblestone appearance. Where will you get cobblestone appearance? Can you tell me where will you get cobblestone appearance? Cobblestone appearance is seen in Crohn's disease. Cobblestone appearance is seen in Crohn's disease. Very good, Naidu, very good. So Karthika, very good. That's a cobblestone appearance seen in Crohn's disease. So this is also a Crohn's disease, but there is a classical appearance. What is this? This is an appearance seen in small bowel. What is this appearance? It is known as serpentine ulcer. Serpentine ulcer or bear claw ulcer seen in Crohn's disease. This is also a Crohn's disease. So this is a picture showing you a lead pipe appearance, looking like a lead pipe in which hastrations are lost. Can you see? Hastrations are lost. Where will you get this appearance? Loss of hastrations seen in? Yes, this is seen in ulcerative colitis. Ulcerative colitis, you get loss of hastrations, and this is a lead pipe appearance seen in the colon. So the next image is a classical image of apple core. This is an apple core seen in cancer colon. In a cancer colon, you get apple core appearance. So the typical picture of apple core appearance. Okay. And this is a repeat FMG question again for your exams. This is a clinical based question. A patient coming to you with the pain, vomiting, fever, and you are doing an ultrasound. Ultrasound shows thick, non-compressible. So thick, non-compressible, blind ending loop you are seeing in the image. Blind ending loop. What is it? It is a case of acute appendicitis. Please don't forget acute appendicitis. You should not forget for your exams. So this is an ultrasound finding. It is more than 7 mm thickness will be present in an acute appendicitis. Don't forget this. So this image is again a high yield MCQ. The picture showing you a barium enema with an appearance like this, known as class sign. Class sign is a feature of intersusception of bowel. So the proximal bowel entering the distal bowel is known as intersusception. So intersusception babies will present to you with a clinical feature of red currant jelly stool. There will be red currant jelly stools will be present in these cases, and you have to take ultrasound. Ultrasound will show you pseudo kidney sign or target sign will be seen in these cases. Pseudo kidney or target sign will be seen in intersusception. The treatment of choice for intersusception is saline or air enema is used for children's. For less than 1 year children, the treatment of this is air or saline enema is used for those cases. A pseudo kidney sign, target sign are used for, are the names given for this. So this question is again a high yield MCQ from intestines. This picture showing you a typical coffee bean sign. This is a picture showing you a coffee bean sign. This is sigmoid volvulus. Please don't forget, this is sigmoid volvulus, typical coffee bean sign shown here. So please don't forget the sigmoid volvulus shown here. It is a coffee bean sign or bent inner tube sign. So what I should do here for this is I should put a sigmoidoscopy and I should sigmoidoscopic reduction is the first line treatment for this case. So first line treatment, the moment you see a sigmoid volvulus, we should do a sigmoidoscopic reduction of those volvulus. Okay. So this question is highly expected again for this year. This picture is showing you a colostomy. The complication of colostomy which has developed here is colostomy has prolapsed. This is a colostomy, prolapse has happened. So this is the colostomy shown here. In right iliac fossa, in the right side iliac fossa, if you see a bowel outside, it is usually a ileostomy. Please don't forget this. In the right side iliac fossa, from the location itself you can tell what stoma it is. Bringing the ileum is in the right iliac fossa. In the left iliac fossa, we bring the colon. So please don't forget this. If you see a bowel at the right iliac fossa, it is ileostomy. If you see a bowel in the left iliac fossa, it is colostomy. Very good, Sugarman. That is the barium enema finding. For barium enema finding of sigmoid volvulus is like this. That is nothing but ace of spade appearance. So ace of spade appearance, but I don't think that at all will come for FMG exams. So that is barium enema showing ace of spade appearance. But this images can be coming for your exam. The right iliac fossa ileostomy, left iliac fossa colostomy. So what is this surgery done here? This is anus. What surgery is done here? This is a picture showing you hemorrhoidectomy done. After pakka hemorrhoidectomy, the anus will look like a clover. If it looks like a clover, the problem is over. This is a line from Bailey and Law. This surgery done is Milligan-Morgan operation. Milligan-Morgan operation. If you have done a pakka hemorrhoidectomy, it will look like a clover. So this is a pilonidal sinus. You can see the pilonidal sinus. This all high yield image based questions. At the gluteal cleft, there can be a small opening. It is pilonidal sinus. Don't forget this. This is also known as Jeepers bottom. Okay. So this again a high yield MCQ for your exam. This is a picture of a baby, newborn baby. We kept a coin at the level of anus and we are taking the X-ray in a inverted position known as invertogram. It is known as invertogram and the diagnosis is imperforate anus. So the picture diagnosis is imperforate anus. Invertogram should be done 6 hours after birth. So it should be done 6 hours after birth. This is a point. Invertogram, imperforate anus is shown in this image. Okay. So this question can be expected in your exam. What is this position for examining the patient by perrectal examination? So this is a perrectal examination done in this position. What is this position known as? This is known as Sims position. For doing a perrectal examination, the position shown as Sims position. So there are two instruments shown here. Don't get confused in the exam. The instrument in the upper one, it is known as proctoscope. The lower instrument is known as what? The lower instrument is known as a rigid sigmoidoscope. Don't get confused in the exam between these two. Rigid sigmoidoscope is 18 centimeter length. Proctoscope is only 10 centimeter length. Okay, this is the two scopes shown here. Proctoscope and rigid sigmoidoscope. Now let us see some of the new pattern questions from this syllabus. Miss Ramya, 20 years female, presented with dysphagia. Please understand dysphagia. She gives history of weight loss for past 2 years. Barium swallow was done, shows abrupt cutoff of contrast. So abrupt cutoff of contrast is nothing but bird's beak. This is abrupt cutoff. This is also known as bird's beak. The answer is achalasia cardia. That's a classical question, very common in young females. Mr. Kumar, 26 years, complains of constant heartburn. He was complaining of night cough. The gold standard investigation to diagnose the disease is pH monitoring. Please don't forget, it is a pH monitoring we have to do for this case. So we have to do 24 hours ambulatory pH monitoring is the best investigation to diagnose this GRD. So Mr. Ramu had a binge of alcohol and vomited suddenly. He developed, please understand the symptoms, he developed subcutaneous emphysema. He developed subcutaneous emphysema, chest pain, following a vomiting. So this is the three symptom I am telling. Vomiting, emphysema, chest pain. What is this? That triad known as? This is known as Mackler's triad. This is known as Mackler's triad seen in Boerhaave syndrome. This is Mackler's triad seen in Boerhaave syndrome. The question is, they are asking, what is the treatment of Boerhaave syndrome? Whenever you see a Boerhaave syndrome, immediately I should do a thoracotomy is needed, urgent. True. Endoscopy is not done. CT scan is needed, urgent X-ray done. So we don't do endoscopy for a perforated case, but we do an X-ray, we do a CT chest, and we have to do a thoracotomy also for this case. Okay. Mrs. Kamala, 40 years female, had severe anemia and presented to hospital. She is having dysphagia for 2 months. Anemia. See the question again. Anemia, dysphagia. These are all catch points. Chylonychia. What is the syndrome now? What is the syndrome? Iron deficiency anemia. Post-cricoid web. They will have dysphagia due to post-cricoid web. This is known as Plummer-Vinson syndrome. Also known as Patterson-Kelly syndrome. Both are same. It is known as Plummer-Vinson or Patterson-Kelly syndrome. Please don't forget. So this is a classical question for FMG exam. A 30 years old Mr. Gupta, HIV positive. See, he is an HIV positive patient coming to hospital with a odynophagia. Endoscopy showed the following findings. Your diagnosis is. So what you see here is a curdy white patch. Okay, you can see a curdy white patch which is seen in candidiasis. Seen in HIV patients. It is curdy white patch seen in HIV patients. So see the question. Mr. Kumaresan, 40 years male, old case of duodenal ulcer, developed perforation and presented to casualty with a guarding and rigidity. Diagnosis over. It is a perforation. What is not done for him? I will take IV fluids, I will give X-ray, I will do rice tube decompression, and I will plan emergency surgery, not elective surgery. I will plan for an emergency surgery, not an elective surgery. So D is wrong. So answer is D, which is not done for him. Mr. Ramu, 20 years old male, non-alcoholic, presents with massive hematemesis and is already having pain in the epigastric region on empty stomach. Usually gets relieved by eating. So please understand, this is a patient having a pain relieved by eating. Catch point is this. Pain relieved by eating means what is that? It is usually a duodenal ulcer. Please don't forget, it is usually a duodenal ulcer which causes pain relieved by eating. Pain relieved by eating is due to duodenal ulcer. So this duodenal ulcer, what I will do? I will immediately do pantoprazole. I will give endoscopy may be needed. So it may be a duodenal ulcer which is bleeding. So I have to do an endoscopy to look for the bleeding. Rice tube decompression will be needed. And octreotide is not needed here. Octreotide is needed for portal hypertension patients. With a variceal bleed only will need octreotide. Otherwise, which is not needed is octreotide will not be needed for these patients. So these are all the typical clinical questions. To understand the concept, you should know everything about the disease. So see the question. Next question I have already discussed. 1 month boy, Master Somu, was brought to hospital by her mother, saying he is vomiting on and off on breast milk. She is also noting some masses happening in the epigastric region. So what is this? It's a case of congenital hypertrophic pyloric stenosis. What is wrong? There is bilious vomiting is wrong. There is non-bilious vomiting will be there. Ramstad's pyloromyotomy is needed. Electrolyte imbalance will be there. Ultrasound is the investigation of choice. So answer is A. Mr. Bhatia, 60 years old male, had history of yearly satiety and weight loss for the past 2 months. Past 2 months he is having yearly satiety and weight loss. So diagnose over, cancer stomach. If there is a cancer stomach, the fellow will have yearly satiety and weight loss. He is complaining of melena. We strongly suspect a disease and send the patient for the following investigations. For a cancer stomach, we don't do PET CT. So we will do CT abdomen, endoscopy and blood grouping for surgery. So PET CT is not indicated in a cancer stomach cases. So that's a direct question. This is actually not an 8P, it is not a FMG question, it's a AIMS question. PET CT not needed for cancer stomach. PET CT will be needed for cancer esophagus. So cancer esophagus we do PET CT, but for cancer stomach we don't do PET CT. This is a protocol. These are all certain protocols from cancer regimens. So this question I have already discussed. Mrs. Ramai, 20 years female, developed a diffuse gastric cancer. See, she is a case of diffuse gastric cancer. She will have the following features except, just now I told you this. E. cadherin mutation will be seen. Lymphatic mets will be seen. Signature cell will be seen. Environmental risk factors are not seen. It is usually due to family history only. It is usually due to family history. So answer is D. Okay, it's due to D. A male patient, yes, there are so many dogs around my house. They are shouting. In between they are shouting. So male patient, 30 years old, underwent endoscopy which showed an antral gastritis. Biopsy showed H. pylori positive. 2 weeks of H. pylori eradication. I think most of you would have had 2 weeks of H. pylori eradication therapy. What is the investigation to know he is eradicated for H. pylori? Now how to know he is clear of H. pylori investigation of choice? To look for eradication of H. pylori. This is a direct one-liner. To look for eradication, the answer is C13 urea breath test. So not culture. Not culture. ELISA and RUT are for diagnosing before the treatment, not after treatment. After treatment, that's a direct MCQ for long years. C13, C14 urea breath test. C13, C14 urea breath test is used for these cases. Okay. So now some old questions. 5-week-old male child is brought to emergency with multiple episodes of non-bilious vomiting. Identify the barium image and diagnose the condition. So it's a clear-cut question showing you a string sign. It's showing you a string sign. So the string sign is shown here. The string sign is seen in congenital hypertrophic pyloric stenosis. Okay, it's seen in congenital hypertrophic pyloric stenosis. So the next question, 10-year-old male child presented with a bleeding per rectum, strongly suspected Meckel's. So Meckel's diverticulum, what is the investigation of choice in child? This is a straightforward question. Very good, excellent. Most of you have answered it correctly. It is technetium 99M pertechneate scan is the investigation of choice for Meckel's diverticulum. Yes, I think yesterday Dr. Khalil sir would have told this as mushroom sign. That's also a nice, this is nothing but mushroom sign, also known as string sign. I used to call it as string sign. So this is technetium 99M scan, straightforward question. 1-year male child has not passed motion for more than 7 days, presented with abdominal distension, and you are doing perrectal examination. Immediately the baby passes stool in the OP itself. This is a classical finding of one disease known as Hirschsprung disease. Hirschsprung disease, when you do perrectal examination, you are dilating the rectum and immediately the baby will pass motion. And Hirschsprung disease, what is the investigation of choice? Is a question that is asked. The answer is suction biopsy of rectum. Okay, that is an answer for diagnosing Hirschsprung disease. So these are all straightforward high yield topics. Hirschsprung disease, what is a diagnosis? So next question is a classical question of AIMS, but there is a catch point for you. I am telling you this is a case of Crohn's disease by seeing the image. What is the skin lesion? Seeing the skin lesion, I am telling this is Crohn's. What is this? They are known as erythema nodosum. It is a dermatology MCQ. Erythema nodosum can be seen in Crohn's. No need to read the theory, that is not for you. Erythema nodosum is seen in Crohn's disease. That's a question I want you to know. The catch point is the patient is having diarrhea, bleeding, bone pain, and is having lesions like this known as erythema nodosum, is the most common skin lesion in Crohn's. This is the most common skin lesion in ulcerative colitis. This is also a dermatology question. What is this? This is a pyoderma gangrenosum. It is the most common skin lesion in ulcerative colitis. In ulcerative colitis, the best treatment is total proctocolectomy. Please don't forget, the best treatment is total proctocolectomy. This is pyoderma gangrenosum showing you ulcerative colitis. Okay. These are all some essential MCQs you should know from dermatology related to surgery. Actually, these are the diseases sometimes we get from the dermatologist. The dermatologist sometimes used to refer, sir, see this patient having pyoderma gangrenosum, kindly rule out ulcerative colitis. Like that, the dermatologist used to refer these cases to surgeons. So this picture is again a classical radiology question. This is known as coiled spring sign. Where will you get coiled spring sign? In a case of intussusception. The patient having a coiled spring sign is shown in intussusception. So this is a last year question. A man presented with a vomiting, nausea and fever. He was admitted for appendicectomy after diagnosing appendicitis. During surgery, surgeons found an incidental finding as shown below. What is this? So it's a baby question, Meckel's diverticulum. See, like that the questions may appear like scaring, but the answer will be very simple. Okay. So this is what I told you. I told you the stomas may be asked in the exam. Now you can see the stoma shown in the right iliac fossa. The question is right iliac fossa. That is two opening. This is one opening. This is one opening. No, this is a type of stoma which is nothing but a loop colostomy. When the loop is kept like this opening and this opening will be seen. So this is loop ileostomy seen in the right iliac fossa. If it is in the left iliac fossa, I would have told it is loop colostomy, but it is in the right iliac fossa. So I am telling you this is a loop ileostomy shown here. So this question is a patient showing you X-ray showing you multiple air fluid levels, distended bowel, and air fluid levels are seen. So this is a case of paralytic ileus. Please remember, this is a case of paralytic ileus. Patient had an abdominal surgery. Patient is in ileus. Everything they have given. The most common cause of paralytic ileus is hypokalemia. Is the most common cause for paralytic ileus. So Mr. Khanna developed pain in the right iliac fossa and took treatment in the local hospital. He was treated with antibiotics and partially recovered. After 3 days, he comes to meet you and note a mass in the right iliac fossa. Ultrasound showed inflamed appendix with a mass. The catch point is here. Appendix surrounded by mass. It's an appendicular mass. What is the treatment? Appendicular mass will always be treated by Aschner-Sharon regimen, non-operative conservative regimen. Mr. Ramu coming to you with an opening in the 8 o'clock position of the anus. So this is an anus. So this is 8 o'clock position. There is a opening. That is nothing but a fistula. So fistula opening is at 8 o'clock. Where it will open inside. So please remember, fistulas located posteriorly will open at 6 o'clock. Anteriorly located fistulas will drain straight in the same position like this. What is this rule? So anterior fistulas will drain straight. Posterior fistulas will drain at 6 o'clock. This rule is known as Goodsall rule. So now where will be the internal opening is the question. There is an 8 o'clock position. There is an opening. Inner opening will be seen at 6 o'clock. Answer is 6. According to Goodsall rule, the answer at the inner opening will be 6 o'clock. So please don't forget this question. So these are last year questions. A male patient comes to you with the itching in the perineal region with the soaking of his undergarment with the purulent discharge. Can you see what is this? This is an anus, and near the anus this is the 8 o'clock position. You are seeing a opening. So this is a perianal fistula. So the inner opening will be seen at 6 o'clock. So this is a perianal fistula shown here. Okay, this bottom images have been asked. 2 questions came last year. So this is a picture showing you a perianal abscess. There is a perianal abscess shown in this image. There is a picture of perianal abscess. So this is a picture of perianal abscess. So the next section is on hepatobiliary and pancreatic surgery. So shall we continue? There are at least some 25% topic is left. Shall I continue, or we'll have another day, another session? Yes. What about you? Because you have been continuously attending the class for 2 hours, 15 minutes. It's being some 25% more topic. At least I need 45 minutes for you. Can you attend the class for 45 more minutes? Shall we continue? If If you are ready, I will continue, or else I will put another session on another day. Yes, we can continue. Most of you are telling yes. Okay, that's great. So I think I will finish before 11. Before 11, I will try to finish. Okay. So these are all just the specialty topics. Usually for FMG exams, the specialty topics, they will concentrate less only. So therefore, let us show the important points alone in the specialty topic. This question has come in your exam. So I hope you know what is Kellard's triangle. Yes, I am continuing. Most of you are ready for the class, so I am continuing. So Kellard's triangle I am now drawing. This is a cystic duct. This is gallbladder. This is a bile duct. So now this is a cystic artery. This is a right hepatic artery. This is a cystic artery. Now you can see this is a triangle bounded by cystic artery, common hepatic duct and cystic duct. So this is Kellard's triangle bounded by cystic artery, common hepatic duct and cystic duct. So this is a boundary. So usually this triangle will have only one structure, that is node. This is Kellard's node. Guys, all the videos will be available in the doc tutorial. I am telling you, you cannot see the video again in the YouTube. All the videos will be available in doc tutorials app. In doc tutorials, you download the app. In the app, there is an FMG section. In that FMG section, you can go and see the videos. It will be available there. I cannot take a break because this is getting recorded. So if I take a break, it cannot be recorded. So I have to complete. So I will finish off in 45 minutes. Just observe. So this is a Kellard's node. So this first image, what is shown here is, instead of cystic artery turning, the right hepatic artery is turning and going inside. What is this anomaly? This question is an FMG, NEET PG, AIMS question. This anomaly of right hepatic artery is known as Moynihan's hump. All the images I have taken only from Bailey and Love. Moynihan's hump or caterpillar turn. Caterpillar turn. Okay, caterpillar turn or Moynihan hump. So what is this anomaly shown here? This is a picture showing you Phrygian cap anomaly. This is an anomaly, most common anomaly, known as Phrygian cap anomaly. So all videos will be uploaded in doc tutorials. Gradually they will upload, don't worry. The rapid revision, everything is available in doc tutorials only. So the app name is doc tutorials. You can download the app and you can see all the videos visible free there. All the videos are free there. All the FMG videos are free there. So this is known as Phrygian cap anomaly. The fundus of the gallbladder folded like a cap. Okay. So what is this? X-ray shows gallbladder. What is this? X-ray shows gallbladder. What is this? This is a picture directly taken from Bailey and Love. This is porcelain gallbladder. So this is a picture taken from Bailey and Love. Porcelain gallbladder. It is pre-malignant. It can lead to cancer. Okay. It is a pre-malignant condition. So dear guys, please don't forget this question. This question is repeatedly asked in FMG exam. I don't know why many of them are answering this again and again wrongly. What is this investigation known as? What is this investigation? Please tell me what is this investigation. It is known as ERCP. You can see the endoscopy here. That's a side viewing endoscopy. With the endoscopy, I am pushing contrast into the pancreatic duct and bile duct and studying that. So this is endoscopic retrograde cholangiopancreatography. The most common complication of this procedure is it can cause pancreatitis. It can cause pancreatitis is the most common complication of this procedure. It is mainly now used for therapeutic to remove the stones from the bile duct. Therapeutic to remove CBD stones, we are using this. To remove the CBD stones, we are using this procedure. Don't make mistake in this procedure. I am seeing students getting confused with this image. This is an MRCP. Magnetic resonance cholangiopancreatography, which is nothing but MRI. It is MRI principle in which the bile itself acts as a contrast. There is no contrast inside. You can see this is not a contrast at all. It is bile. Bile in the biliary system that acts as a contrast. This is MRCP. It has now replaced ERCP for diagnosed. It has replaced the ERCP for diagnostic purposes. So what is the sign seen in the next image? There is a sign seen like this. What is the sign? This is known as Mercedes-Benz sign. It is a finding in gallstone. Please remember, it is a finding in gallstone. You get this Mercedes-Benz sign in the gallbladder. So this is a sign again. In a MRCP, you are seeing a sign at the lower part of CBD. There is a sign like this. What is this sign? It is known as meniscus sign. It is due to CBD stone. Due to CBD stone, you are getting a sign known as meniscus sign here. It is a meniscus sign. So in the next image, I am showing you 3 stones. The most common stone all over the world is mixed stone. Most common stone in West is cholesterol stone. World is mixed. In India and Asia, the most common stone is brown stone. Most common in Indians and Asians is brown stone. In children, it is black stones. So please don't forget the 3 common stones. So where can I get the stones? So most common stone in children is black stones. Brown stones, it is most common in Indians and Asians. And cholesterol stone is most common in West. Mixed stone is most common in world. So what is the cause of black stone? It is usually due to hemolytic anemias. Brown stones is mostly due to infection like Proteus infection. Sorry, not Proteus. Proteus is for kidney stone. The infection here is E. coli infection, Klebsiella infection. These guys causes stones known as brown pigment stones. So please don't forget, it is brown pigment stones. So for Maria Khan, for patients with the biliary pancreatitis, that is a treatment. We have to do sphincterotomy. Then only the biliary pancreatitis will get relieved. That's correct. Biliary pancreatitis, we have to do ERCP. So this question is a repeat FMG question. High yield FMG question. So ultrasound shows a stone with a posterior acoustic shadow. It says posterior acoustic shadow. This is a typical gallstone. Please don't forget, no doubt at all. The gallstone shows posterior acoustic shadow. So this is a picture showing you a T-tube. So which is kept inside the bile duct after removing the stone by surgery. If I remove the stones from the bile duct by surgery, after surgery I will keep the T-tube inside the bile duct like this. T-tube is this. So T-tube is used in the CBD. Okay, so don't forget T-tube. So next picture is showing you a T-tube cholangiogram. Can you see? This is a picture showing you T-tube. Through the T-tube I am doing a cholangiogram. That is showing a stone in the bile duct. That is showing a CBD stone is shown inside. That is showing a stone in the bile duct. CBD stone is shown. So T-tube cholangiogram showing you CBD stone is the next image. So what is this image showing you? This is an image showing you a pancreas which is encircling the duodenum known as annular pancreas. It is characterized by clinical feature of bilious vomiting. Please remember, it will have bilious vomiting feature in a newborn baby. And please don't forget, it is due to embryology. What problem? Non-rotation of which bud? Non-rotation of ventral bud causes this problem. And treatment is duodenal or duodenojejunal anastomosis. We have to do duodenal or duodenojejunal anastomosis should be done for annular pancreas. So the next patient is a patient with a pancreatitis having 2 signs. Pigmentation around the umbilicus known as Cullen sign. Pigmentation around the flanks known as Gray Turner sign. And if there is a pigmentation in the inguinal region, it is known as Fox sign. So pigmentation in the umbilicus, Cullen's, Gray Turner's, Fox. Yes, these guys also have a double bubble. Annular pancreas patients also will have double bubble. That is true. They also will have double bubble. So Cullen sign for umbilicus, Gray Turner for flank, and Fox for inguinal ecchymosis. So this is a classical finding seen in X-ray of patient with acute pancreatitis. What is it? X-ray of acute pancreatitis patient is showing you one sign. This sign is known as colon cutoff sign. So colon cutoff sign is a finding in acute pancreatitis. Very good. So this question can come for you as an image based question. Please don't forget the question will have history of chronic alcoholism. History of chronic alcohol. Patient recovered from a pancreatitis recently. Now presents to you with an epigastric swelling. When you take a CT scan, that CT scan shows a huge cyst. What is the diagnosis? It is pseudocyst of pancreas. So please remember, the patients will come to you with a cyst known as pseudocyst of pancreas. So this is a picture showing you MRCP in which you can see the two ducts are separated. They should join. No, in the previous picture you see the ducts will be joining. If you see the previous MRCP picture, I will show you. In this MRCP picture, if you see, they will be joining like this. They both will join. If they are not joining and they are separated, it is known as a double duct sign. This is a picture showing you double duct sign. Double duct sign is a feature of cancer head of pancreas. Cancer head of pancreas will have double duct sign, or even periampullary cancer also will have double duct sign. So the cancer at the ampulla level, if there is a cancer, it will have separation of the duct. Very good, Shagarman. That is known as double duct sign. Please don't forget. So this is Courvoisier law. I want you to know what is Courvoisier law. So if this is a bile duct, if the bile duct is obstructed by a stone, if it is obstructed by a stone, please remember, if it is obstructed by the stone, the gallbladder will not enlarge because it is already fibrosed. Therefore, it will not enlarge. But at the same time, if it is obstructed by some cancer in the distal place, the gallbladder will enlarge. Cancer cases, gallbladder enlarges. If it is due to stone, the gallbladder will not enlarge. This is a simple Courvoisier law. From this picture, you can see the gallbladder is enlarged. So, it is a periampullary cancer. This is one of the patient with the cancer in the periampulla. That is the reason gallbladder is enlarged. So, don't get confused with the Courvoisier law. So, the investigation of choice for cancer pancreas is CACT abdomen. And what is the tumor marker for cancer pancreas? Tumor marker. This is an expected MCQ. Tumor marker for cancer pancreas is CA19-9. The tumor marker for cancer pancreas is CA19-9. Okay. So this is a picture showing you what surgery. This is expected image based question for your exam. Identify the surgery shown here. High yield MCQ. Identify the surgery shown here. Most common cause of death in this surgery. I want you to know these two questions because these two questions are asked in NEET PG recently. Recently asked question. What is a CA99 is correct. Jayashri, it is not 99.9, it is 19.9. Not CA. CA99 is the answer. So this surgery shown here is known as Whipple's operation. Please don't forget. It is known as Whipple's operation, in which we will remove the distal part of body of stomach, entire duodenum, gallbladder, bile duct, head of pancreas, everything is removed, and we do 3 anastomosis. Pancreatico-jejunostomy, you can see the gastro-jejunostomy, pancreatico-jejunostomy, and hepatico-jejunostomy. You can see this is HJ, this is GJ, this is PJ. 3 anastomosis are done. This is Whipple's. The most common cause of death is leak of this anastomosis. Leak from the pancreatico-jejunal anastomosis is known as most common cause of death. So please don't forget, this image can come for your exam. What is the surgery done here? It is known as Whipple's. So this is a picture showing you the liver segments. The question I want you to remember is, what is the line which is dividing the liver into right and left? So there is a line which is shown to divide the liver into right and left before dividing it into 8 segments. What is the name of the line? That line is Cantel's line, which runs along middle hepatic vein. It runs along the middle hepatic vein. Roux-en-Y is not to be confused with the Whipple's. Roux-en-Y is different. Don't get confused with the Whipple's and Roux-en-Y. I am drawing the Roux-en-Y here. This is a stomach means. This is a duodenum means. This is DJ flexure. See, this is a jejunum coming. No, I will cut the jejunum and bring the jejunum and anastomose like this. And bringing the jejunum and anastomose in here. This is gastro-jejunostomy. Only jejuno-jejunostomy. We are not doing anything on the pancreas. We are not doing anything on the pancreas. We are not doing anything on the gallbladder or bile duct. So this is Roux-en-Y, GJ, JJ. This is Roux-en-Y. Don't get confused with the Roux-en-Y and Whipple's. So don't get confused. So this is Cantel's line, which is running at the middle hepatic vein. So segments are, sector is different. There are 4 sectors. You see, there are 4 sectors. A left lateral like that you see. I don't think that at all will be asked for FMG exam. So this is left lateral. This is left lateral. This is left medial. This is right posterior. This is right anterior. These are the sectors. These are the sectors. The segment, if you want, we have 8 segments. We divide them into further, based on the portal vein, divide them into further 8 segments. So there are 8 segments and 4 sectors, and the main thing they may ask you in your exam is, they will ask you what is the line running to divide the liver into right and left. That is known as Cantel's line. Okay, Cantel's line. So what is this maneuver shown here? Can you tell me what is this maneuver shown here? Dawit Shaikh, the Bilrath one is gastroduodenal. This is stomach, this is duodenum. Gastroduodenal anastomosis is known as Bilrath one. So gastrojejunal like this is known as Bilrath 2. You have to keep drawing, then only you will understand them. So Bilrath 1 is gastroduodenal, Bilrath 2 is gastrojejunal. So what is this maneuver shown here? So Roux-en-Y you can do anywhere. It is a type of reconstruction. There is no strict protocol. Anywhere you want you can do Roux-en-Y. Anywhere we can do any type of reconstruction. There is no specific protocol. But Roux-en-Y is having better advantage of non-bile reflex. Okay. So this is Pringle maneuver. Very good. Pringle maneuver is an inflow occlusion maneuver. Occludes the hepatic artery and portal vein blood. Hepatic artery and portal vein blood entering the liver will be occluded. Maximum we can do it for 45 minutes only. We can do it for maximum 45 minutes. So what is this picture showing you? This is a high yield image based question for FMG exam. This is Sengstaken Blackmore tube, which is modified. Modified tube has 4 lumens. Okay. Modified tube is also known as Minnesota tube. Minnesota or modified Sengstaken Blackmore tube. So what is this? Yes, it's at the foramen of Winslow. That's correct. It is a Pringle maneuver. So this is used for, indication of this is to arrest the variceal bleed. Arrest variceal bleed is the use of this. Okay, please don't forget it is used to arrest the variceal bleed with the help of this tube. So this is picture showing you what procedure is going on here. What is the procedure going on here? This is TIPS. Transjugular intrahepatic portosystemic shunt. You can see the stent kept between the hepatic vein and the portal vein. Between the hepatic vein and the portal vein we keep a stent known as TIPS. This is a picture showing you TIPS. Okay. Yes, it's Minnesota tube, also known as modified Sengstaken Blackmore tube. Okay, both are same. So this is a pyogenic abscess. The most common route of infection of liver is through the biliary route. Please remember, the bacterial infection is mostly through the biliary route due to cholangitis. Due to the bile getting infected, and the cholangitis causes this pyogenic abscess. Most common organism is E. coli and Klebsiella. This is a picture showing you a pyogenic abscess. If it is an amoebic abscess, it will be like this. The abscess will have a color of anchovy sauce pus color. How to differentiate? As surgeons, how we will differentiate whether it is a pyogenic or anchovy is by taking a CT scan. This is a picture showing you, CT scan showing you clustered irregular abscess. What is it? Pyogenic or amoebic? It is pyogenic abscess. With only CT scan we find them. Clustered irregular abscess is pyogenic. Well-defined abscess. Well-defined abscess is amoebic. Simple method to differentiate. With the CT itself we can say whether it is pyogenic or amoebic. So this is having a well-defined abscess. This is a pyogenic will have irregular clustered abscess. So this is a picture of hydatid cyst. This can involve the liver, and when it involves the liver, the following findings are seen. Number 1, calcification is a feature of hydatid cyst. Honeycomb appearance. Honeycomb appearance is hydatid cyst. Water lily appearance. Don't forget this water lily sign. Water lily sign is nothing but if there is a cyst, you can see the floating membranes like this. Water lily or water snake sign. These are all the findings seen in amoebic, in a case of hydatid cyst. Yes, amoebic abscess, all the abscess, everything is seen on right lobe only. Amoebic abscess, hydatid cyst, everything will be seen on right lobe only. You can see this is one of my patient with a hydatid cyst on the right lobe. Calcified cyst, fully calcified cyst on X-ray. So what is this picture showing you? This is a spleen. Near the spleen you are seeing some small spleen like things. They are known as ectopic spleen. Ectopic spleen, most common site is hilum of spleen. In the hilum of spleen itself, we get the most common site of ectopic spleen. Okay. So let us see some MCQs from this chapter related to FMG new pattern. Mrs. Sandhya, 40 years obese female, presents with severe right hypochondrial pain. She had Murphy's sign positive. Ultrasound showed gallstones multiple in number. What will be the ideal treatment for her? Can you tell me? Murphy's sign positive. So definitely she is a case of acute cholecystitis. I will plan for laparoscopic cholecystectomy as early as possible. I will do the laparoscopic cholecystectomy for her. Mr. Ramu, 40 years male, presented with fever and chills. On examination, SGOT, SGPT increased. Serum bilirubin is more than 10 milligrams per deciliter. See, the bilirubin is increased means there is a stone in the CBD. So what is the next step? This question just now I told you. These are all direct FMG questions. Next step, if there is a CBD stone, I will do ERCP and stone removal. That's the correct straightforward answers. No confusion, no controversy. Patient having a CBD stone, I have to remove it by ERCP. Mr. Guptakar, 80 years male, presented 80 years. See the history. 80 years male, right hypochondrial pain, fever, guarding. Total count is 25,000. Very low BP. Creatinine is increased. Very sick patient with acute cholecystitis. There is one guideline known as Tokyo guidelines. According to Tokyo guidelines, which they may not ask you, they fall under grade C. Very severe grade. Such cases we don't do surgery. We do only a percutaneous tube. Percutaneous cholecystostomy is the only treatment we can do for this guy. That is answer for this case. 30 years female, operated for laparoscopic cholecystectomy, developed post-operative fever and right hypochondrial pain. So patient had a right hypochondrial pain and right hypochondrial pain and fever. That means he is having a leak and he is having a collection in the right hypochondrium that is having 8 cm collection. Ultrasound shows there is a leak and collection. Immediately what will I do? Immediately I will call the radiologist and come put a tube here and remove the bile. So ultrasound guided drainage is immediate next step for a suspected leak case. Okay. So suspected leak case, immediately I should put a percutaneous drainage. Mrs. Kamala, when planned for laparoscopic cholecystectomy surgery, on inserting the camera, you are a junior surgeon, you are noting there is a cancer in the gallbladder. What will you do? You are a surgeon thinking it is a cholecystectomy only you are going to do, and you are going to put the cannula. The moment you put the cannula, you are seeing there is a cancer. What are you going to do? I will remove the port and refer to gastrosurgeon. That's the answer for this question. The answer for this question is, because it is a cancer, it will need a radical cholecystectomy. I will remove it and send the patient to the gastrosurgeon. That's the answer for this question. Okay. So the last section we have come now, urology we have come now. So now this is a question, first picture showing you directly taken from Bailey and Love, the narrow points of ureter. So the narrow points of ureter, I want to tell two questions. So if the stone is obstructed in the uretropelvic junction or in the pelviureteric junction, we call it as PUJ stone. What will be the symptom? And if there is a stone obstructing at the VUJ stone, vesico-ureteric junction stone, what will be the symptom? So don't get confused. Pelviureteric junction is this. This is vesico-ureteric junction. There may be many places it cannot get obstructed, but in these two places, so you can get the PDF in Surgery 6er Telegram channel. You can get it in the Telegram channel. So PUJ stone will have pain radiating from loin to testis. What nerve carries the pain? Loin to testis. The nerve carrying is genital branch of genitofemoral nerve. Vesico-ureteric stone, that is a stone coming from, radiating from loin to groin, from loin to thigh or groin. So this is due to iliohypogastric nerve. So don't forget these two nerves. What is the nerve carrying the pain is iliohypogastric nerve for VUJ stone and genital branch of genitofemoral nerve for PUJ stone. Okay. Say about this picture. What is this picture showing you? This is a different type of stone known as staghorn stone. This is known as staghorn stone. it is a staghorn calculi you are seeing in this image. It is usually a stone made up of calcium, magnesium, ammonium, phosphate stone. So it is a staghorn stone. The treatment for these stuck ஆயிடுச்சு நெட் இல்லையா I think it has come back. Hope I am coming back. Yes, it's back. Yes, it's fine now. There is some problem from the software persons, not from me, from my net. My net is fine. So this is spider-leg appearance seen in polycystic kidney disease. Okay. So the IVP I am showing you here is spider-leg appearance seen in polycystic kidney disease. So classical question, actually it's a AIMS question. This is having an appearance here. What is this? Flower vase appearance. Can somebody tell me? These are all direct one-liners of FMG exam. Flower vase appearance seen in horseshoe kidney. Horseshoe kidney. So I have not done anything. Staghorn calculus. Staghorn calculus is nothing but struvite stone or jack stone. It is also known as staghorn stone or struvite stone. It is most common in proteus infection. I have shown you the procedures. This is ESWL. This is PCNL. So please remember this instrument, nephroscope, is asked as an image-based question in AIMS. So nephroscope. So what is going on in this? In a ureteric stone we are removing by Dormia basket. This is ureteric stone removed by Dormia basket. This is spider leg appearance seen in polycystic kidney disease. And this is a shaking hand appearance or flower vase appearance. Some people also used to call it as shaking hand, but ideal term is flower vase like appearance seen in horseshoe kidney. The fusion of the kidney is seen at which vertebral level? Means it is seen at L4 level. At L4 level the fusion is usually seen. Okay. So the criteria for PCNL, I will tell you, ESWL can be used up to 2 centimeters. Stone up to 2 centimeter we can use ESWL. More than 2 centimeter, infected stone, obstructed stones, all these cases we use PCNL. More than 2 centimeter, infected, obstructed stones, we use this PCNL. Okay, staghorn calculus I didn't tell anything. So staghorn is typically staghorn is a stone which is having a multiple calyceal appearance. It is also known as struvite or jack stones. It is most common in proteus infection. Okay. So urology, if you want a detail, it is available. Don't worry. So this again a classical IVP appearance. What is this? This is having an appearance like this. What is it known as? This is cobra head appearance in urethrocoel. 2 cm infected obstructed stone. 2 cm infected and obstructed stone. So this is cobra head appearance seen in urethrocoel. So this is a classical question I want you to remember. This is a procedure going on here is TURP. Transurethral resection of prostate for BPH I am doing here. I should stop at distal which place? I am doing removing prostate. I should stop at one place. This is the distal limit. I should not resect beyond this because there is external urethral sphincter here. Therefore, I stop at this place known as verumentanum. This question is again a NEET PG question. So, distal limit of transurethral resection of prostate is verumentanum. Very good, Chagarmane. Very good. That is a place where we have to stop it. So, what is this? This is a case of hypospadias in the penis. Typical hypospadias. In hypospadias, there is a ventral opening of urethra. You can see ventral urethral opening, ventral cardi, and dorsal hood. What surgery should not be done for these babies? Can you tell me what surgery should not be done for these cases? We should not do circumcision. Circumcision is contraindicated as circumcision should not be done for these babies with the hypospadias. Okay. So very interesting next picture, definite MCQ for your exam. What is this? The penis is seen on X-ray itself. You are seeing the penis and this fellow is having a erect curved penis. What is this penis known as? This is known as Peyronie's disease. Peyronie's disease is a calcified penis and the treatment done for these cases is Nesbit operation. Nesbit procedure is a procedure done for these cases. Okay. So what is your diagnosis in this case? The case is having a picture showing you bag of worm sensation, bag of worms like appearance in the scrotum. It is nothing but varicocele. The treatment done is Paloma operation. Paloma operation. So Paloma operation is operation done for varicocele. Okay. So this is a picture showing you torsion of testis. Can you see this testis is under torsion and it has gone for gangrene. I hope you will be knowing one test to differentiate torsion from architis. That test is known as Prince sign. To differentiate torsion from architis, when you lift that testis, the pain decreases. Pain decreases in architis. It increases in torsion. So torsion is a very dangerous problem. You should be very careful with that. So don't worry about the angel sign and other sign. They may not ask you, but they will ask you only this Prince sign. Prince sign to differentiate architis and torsion. So the most common anomaly seen is bell clapper deformity. I will show you the bell clapper deformity that will come in MCQ. So bell clapper deformity is a cause of torsion, and please remember torsion always explore both sides. You should explore both the sides at the same time. Okay. So now coming to the vascular surgery, what is the name of this catheter? Can you tell me what is the name of this catheter? This is known as Fogarty balloon catheter for embolectomy. For embolus removal, we use this catheter known as Fogarty balloon catheter. High yield MCQ already asked in AIIMS. Sometimes the FMG examiners, they ask questions of old AIIMS question. So this is Fogarty balloon catheter. This is a finding of lipodermatosclerosis. Lipodermatosclerosis patients of varicose veins, they develop this deformity. What is it? This is known as inverted champagne bottle leg. Inverted champagne bottle leg is shown in this image. Okay, don't forget this deformity. I'll be sharing this PDF, don't worry. So this is a picture showing you a varicose ulcer. Please don't forget, this is a picture showing you a varicose ulcer. And from this varicose ulcer, we have developed a cancer. What is this? That's my question. From this varicose ulcer or a burns scar, there is a cancer developed. What is this cancer known as? This is Marjolin's ulcer. Marjolin's ulcer is nothing but a squamous cell cancer. It is a Marjolin's ulcer which is nothing but a squamous cell cancer. So name this sign. It is a sign seen on duplex Doppler scan. Doppler showing you, color Doppler scan showing you a finding in a varicose vein. What is this sign known as? This is known as Mickey Mouse sign. So Mickey Mouse sign is an image based question asked in the exam. So please don't forget Mickey Mouse sign. Okay. So this question is a picture showing you a partial thickness graft. Please don't forget this is partial thickness graft, also known as Thiersch graft. It is known as Thiersch graft. So it is done with the help of this knife known as Humby knife. With the help of this knife only we take this partial thickness graft. The major problem with this graft is it can go for contracture and it will look cosmetically ugly looking. It will be cosmetically ugly looking and it will go for contracture. That is a problem with Thiersch graft. Okay, it will go for contractor and partial thickness. Yes, this is known as many jokes. Some students in between the students are some of you are cracking, but I am having no time to discuss them. Sashi Kumar is asking whether it's a Vijay fan. I am a Rajini fan only, man. I am not Vijay fan. We are old generation people, know. So this is a full thickness graft. Okay, this is a full thickness wolf graft. This is a wolf graft. Wolf graft, the major advantage is it is cosmetically good looking. Can you see the follow-up picture showing you the graft being not at all done? It is cosmetically good looking. Okay, it is good looking cosmetic graft. So wolf graft is a full thickness graft. So this question I am expecting this year for your exam. This mastectomy being done here, and for reconstruction of the breast they are using the fat in the lower part of abdomen based on inferior epigastric artery. They are using that. So what is it? That is DIEP flap. This is a flap used for breast reconstruction known as deep inferior epigastric perforator flap. So deep inferior epigastric perforator flap is shown here, okay, for breast reconstruction. So reimplantation of a cut digit. Can you see how are you going to bring the cut digit? A cut finger is first washed with the tap water. Sterile gauze, you roll it and keep it in a plastic bag. Then only you should keep in an ice bag. So this is how you should transplant the finger. Okay, wash in a tap water, keep it in a sterile gas, put it in a plastic bag and put that plastic bag in an ice container and refer to the surgeon, plastic surgeon, who is going to reimplant in 6 hours. It should be reimplanted. The structure anastomosis B fans is the mnemonic. First you do bone, second you do extensor tendon, then you do flexor tendon, order of reconstruction, artery, vein, N for nerve, last S for skin. So the mnemonic is B fans. Is a mnemonic for order of reconstruction of cut digit. Okay, so bone, extensor tendon, flexor tendon, artery, nerve, skin. Okay, that is order. So what is this finding? Pediatric surgery question. So this is a picture showing you congenital diaphragmatic hernia. What is the name of the hernia? So the most common hernia is the defect in the posterior part of diaphragm known as Bogdalak hernia. This is a Bogdalak hernia. Most common content to go inside is stomach. This is a Bogdalak hernia with the stomach as a content. Okay. So this will be uploaded. Don't worry. This will be uploaded in Dr. Tutorials app. Okay. I think most of the students are not knowing it is uploaded in Dr. Tutorials app. So please see these videos in Dr. Tutorials app. So this is a picture showing you what? This is a picture showing you what? Definite MCQ for your exam. This is gastroschisis. There is no covering membrane. That is known as gastroschisis. If there is a covering membrane, it is known as amphoulocele. Definitely they may ask you these questions. Without covering membrane is gastroschisis. With a covering membrane is known as examphoulose or amphoulocele. It is known as examphoulose or amphoulocele. So what is the most common brain tumor in adults? So there is most common brain tumor in adults is METS. I am asking you the most common primary brain tumor. Primary brain tumor is GBM, glioblastoma multiforme. This is the most common brain tumor of adult and it is also known as butterfly tumor. Many pathologists and many other books they will be telling you as meningioma. Please remember, meningioma is the second common tumor. It is not the most common tumor. This is from neurosurgery books. So meningioma is not the most common. Glioblastoma multiforme is the most common brain tumor. So this is a picture of meningioma. Meningioma can be diagnosed just with the finding that it is calcified. Calcification is seen in meningioma and they have good prognosis. They have good prognosis. Please don't forget this. Okay. So they are the FMG. The download link is given by in the chat. You can see the chat. They are showing you the link to download and see the thing. So this is a histopathology of meningioma. You can see here also you can get a samoma body. Samoma bodies. So it is seen in papillary cancer of thyroid, papillary cancer of RCC, meningioma, prolactinoma, serous adenoma. In all these places you can get this samoma bodies. So what is this skin cancer? You have a highly repeated MCQ. What type of skin cancer is shown here? This is known as rodent ulcer, and also known as tear cancer, also known as basal cell cancer is the most common skin cancer. Okay, it is known as most common skin cancer. It is seen along the tear flow area. It is seen along the tear flow area like this. So it's a most common skin cancer. Okay. So now let us finish the syllabus with the questions. Which of the following is the best management for a 3 cm stone? Already I told you the answer. What is the answer? 3 cm stone, it is PCNL. Okay. More than 2 cm we should go for PCNL. 40-year-old man after transurethral resection for BPH develops seizures in the post-operative period. What is the diagnosis? This is a repeat MCQ. The patient was done transurethral resection of prostate and during surgery they used distilled water. So because distilled water is used, that will be absorbed in the body and the patient will develop dilutional hyponatremia. And this is known as water intoxication is the answer for these cases. Okay, water intoxication is the answer for these cases. Bell clapper testis predisposes to. Just now I told you, the testis will be lying like this. Usually testis should be like this. If the testis lies like this, it is known as bell clapper testis. That is known as torsion. So torsion is the bell clapper testis. There is a picture showing you a bell clapper like appearance of testis. It can go for torsion. Cardi is associated, all these are FMG questions, old pattern FMG questions. This is associated with hypospadias. Ventral cardi will be seen. So what is the most common complication of stripping the varicose veins below the knee? When you strip the varicose veins, we can injure the saphenous nerve or sural nerve. Sural nerve laterally and saphenous nerve medially may be injured and you can cause neuralgia. That is a problem of stripping of the varicose veins. Like this, when you strip the varicose veins below the knee, you can strip the nerve also and you can cause pain. I hope you know what is Buerger's disease, the disease of Indians. You can get this question in your exam. Buerger's disease is also known as thromboangiitis obliterans. It is also known as thromboangiitis obliterans. There may be superficial thrombophlebitis will be seen. Nerve involvement may occur. Ulnar and peroneal vessels are involved. So there will be hypohidrosis is wrong. There is nothing related to sweating and all is not related. So thromboangiitis obliterans will involve medium-sized and small-sized vessels. Medium-sized and small-sized arteries will be involved. It involved veins also involved, nerves also involved. It also involves upper limb also is seen. But very important MCQ I want to know you here is, this is most common in less than 40 years males who smoke very severely, more than 20 cigarettes per day they smoke, they only will get this Buerger's disease. This is very rare in Western country, very common in South India. Because of severe smoking, this is seen. This is a question directly from FMG books. What is xenograft? Xeno means from one species to another species. Transplant from one species to another, from other species to human is known as xenograft, and usually we get organ from pig. From pig we get heart valves. That is a xenograft. Okay, that is a xenograft we get. Craniopharyngioma is a brain tumor arising from Rathke pouch. So craniopharyngioma appear like supracellular calcification. Supracellular calcification it is seen and it appear as Rathke's pouch. So that completes the class. It's very difficult to complete the task in 2.5 to 3 hours. I tried my best. So I think those who are already prepared for the exam may be feeling this is a little easier. And this is one of the very interesting session I saw. Around 1200 students attended at a time. That's a big number. Until the end of the session, there are around 758 students still attending the session. That's a great thing to see, because to sit and listen for the class for 3 hours itself is a big task. When you are sitting and listening for 3 hours continuously, means you have that energy, you have that force, you have that motivation to get crack the exam and get a seat. I am sure because of this passion and energy you are having, definitely you are going to crack this exam, FMG exam, and we are expecting this year the pass percentage of FMG will be very high in the past few years, and definitely most of you are going to clear the exam to come and work in the COVID wards. So all the best for your exams. So keep following